Honorable Ministry of Health, distinguished guests and esteemed colleagues. First of all, let me start by thanking the Institut. Let me start by thanking the Institute of Economy of Barcelona for the co-organization of this event with us. And if you allow me, in particular, I want to thank the president of the foundation, Martí Parellada, and especially Judit, who has managed very well to bring together an impressive group, as you see, of experts of healthcare policy. We are absolutely delighted to welcome all of you at our home, the Institute of Self-Government Studies, and I really hope that you will enjoy and benefit from today's discussions. As you might know, the Institute of Self-Government Studies I have the honor to direct is a public research institution dedicated to the study of a state's territorial organization, which means, among other things, how power is distributed across governmental levels and who has the responsibility in each case to design and implement specific policies. With no doubt, the subject of today's workshop is thus an issue that fits perfectly in the research activity of today and on the interest even for the Catalan government. We have now the Ministry of Health, and I think the analysis of the challenges of the expected and unexpected also effects of the innovation issues that public authorities have to face in complex multi-level governance systems. Specifically, the immense, huge, daring challenges they have to face when dealing with the design and implementation of relevant policies, such as health, that involve, as you know, the participation of a myriad of actors, not only from the public sector, and also from the society and the private sector. Senyores i senyors, com vostès saben, a l'estat espanyol la sanitat és un dels pilars fonamentals de l'estat del benestar, i no només això, sinó que és una de les polítiques públiques que estan descentralitzades. Tanmateix, la complexitat del sistema de distribució de repartiment competencial a Espanya fa que hi hagi un marc de compartició o de repartiment de funcions o d'atribucions entre l'Estat i les regions o les comunitats autònomes. Per una banda, l'Estat té la competència exclusiva per fixar les bases, és a dir, un mínim comú normatiu que ha de deixar marge al desenvolupament normatiu per part de les comunitats autònomes. Aquest és un element sempre conflictiu i difícil en les relacions amb l'Estat i segurament la font de conflictes més habitual entre l'Estat i les comunitats autònomes davant de la Cort Constitucional, el Tribunal Constitucional espanyol, i per l'altra banda també l'Estat té atribuïda una funció rellevant com és la coordinació, que és un instrument o un mecanisme de col·laboració de caràcter vertical. Òbviament sempre hi ha algú que coordina i algú que és coordinat i tot això es fa a través de mecanismes de relació multinivell, multilateral, en el nostre cas el Consell Interterritorial del Sistema Nacional de Salut. De la seva banda, les comunitats autònomes, com segurament sabran, els ens subestatals assumeixen la majoria de funcions en l'àmbit de la salut i té competència pel que fa a la gestió ordinària. Tant és així que en aquests últims temps hi ha hagut, òbviament, diferents conflictes des del punt de vista competencial. Vull referir-me molt concretament a la gestió d'un repte molt recent com la contingència de la crisi sanitària, de la pandèmia de la Covid-19. L'estat espanyol va ser un dels únics pocs estats a la Unió Europea, juntament amb Portugal, que va acudir a un mecanisme tan excepcional com l'estat d'alarma, que implica una recentralització del poder de presa de decisions, un model que es va revelar al cap de molt poc temps un model fracassat, en la mesura que l'Estat no disposava de l'expertise, del know-how, del coneixement dels recursos humans per poder fer ni el rastrejament de positius ni l'adquisició del material sanitari necessari. Finalment, aquest model va acabar revertint. Finalment, a partir del maig del 2020, en el model que es va denominar i va fer fortuna de la cogovernança a través d'un instrument de col·laboració, no tant de coordinació, com va ser el propi Consell Interterritorial, aquesta conferència sectorial que va esdevenir un vehicle ja no només d'intercanvi d'informació, sinó també d'autèntica presa de decisions en conjunt. Però, òbviament, aquesta no ha estat històricament una situació absolutament idíl·lica. I pel que fa al finançament, que és la qüestió que avui ens ocupa preferentment, bé, si les comunitats autònomes, com deia, són les encarregades de la gestió ordinària de la salut i de les polítiques públiques en l'àmbit sanitari, no ha d'estranyar que més del 90% de la despesa pública sanitària a l'estat espanyol correspongui a les comunitats autònomes. I no només això, sinó que la sanitat ocupi un lloc preferent i molt destacat en el conjunt de les polítiques públiques en l'àmbit de l'estat del benestar. Només a Catalunya el 26% de la despesa de la Generalitat l'any 23, en el pressupost de l'any 23, anava destinat a salut. I això és una dada, ben reveladora de la importància del pes específic que té la salut en el conjunt de les polítiques públiques d'aquest país. Tanmateix, segons un estudi recent d'una universitat pública catalana, la Universitat Pompeu Fabra, concretament del seu centre de recerca en economia i salut, amb dades del 2001 ens deia que Catalunya té un dèficit pel que fa a la despesa pública sanitària de l'ordre de 3.000 milions d'euros, que és una quantitat molt important. I, evidentment, aquesta xifra, que és important, s'ha anat reduint a poc amb el pas del temps, però continua sent un repte majúscul, un repte molt important, el fet d'assolir la plena sostenibilitat econòmica i financera, perquè estem parlant del 22% pràcticament del total de la despesa pública registrada l'any 2021. Per tant, des d'aquest punt de vista ja veuen que vivim en un context a Catalunya de tensions des del punt de vista competencial i de tensions també des del punt de vista de la tresoreria. I per tal d'assolir concretament aquests objectius, una millora de la qualitat assistencial, per tal d'assolir, òbviament, una millora també en la inversió en recursos humans, en mitjans materials, en la deguda capacitat dels nostres professionals, calen més recursos. Estem en un context en què previsiblement en la propera legislatura es podrà negociar un futur model de finançament. Des de Catalunya el govern ha estimat el dèficit fiscal a l'entorn del pràcticament el 10% del PIB, aproximadament 22.000 milions d'euros, dels quals una part important, com he dit, correspon a la sanitat. I per tant, i amb això acabo, espero que els treballs que avui farem en aquest workshop amb tots els col·laboradors importants que venen de fora i des de la perspectiva, òbviament, comparada, ens ajudin a aprofundir en aquesta qüestió, no només per aquesta dificultat que tots tenim en aquests moments de dificultats des del punt de vista econòmic o financer, sinó també pel que suposa de repte immens en un àmbit com la sanitat, que té un gran potencial pel que fa, òbviament, a assolir objectius d'equitat, d'eficiència, de capacitat i de resposta en la prestació de l'assistència sanitària dels nostres conciutadans. Gràcies a tots i bona feina. Moltes gràcies.
Good morning, all of you. First of all, I would like to thank the possibility to share this presentation with the president of the Institute of Studies of Self-Government, and especially with the presence of our minister of the Catalan Government of Health. This is very important because recognize the importance of this initiative. For us, for the institution that I represent, Barcelona Institute of Economics, is important this act, this activity, this workshop. It's important because it starts with a meeting the last September with the president of Institute of Studies of Self-Government about that they studied the possibility to explore the collaboration between the Institute and the Barcelona Institute of Economics. We have in the Barcelona Institute of Economics, that is a research center of the University of Barcelona and the Autonomous University of Barcelona, is a research center with probably the main research line of the Institute has been and is the fiscal federalism. We try to explore with the president, with Joan Ridao, to explore the possibility to do something around this topic. Logically, one of the questions that we presented there was the possibility to study the funding regime of the regions in Spain. But we considered at that moment that this is a very complex topic. Finally, in relation to this topic, there are positions extraordinarily separated among the political parties, among the society. No? And a consequence of this, we consider that we could start speaking about the expenses. And logically, the main important expenses of the regions in Spain, and probably the main important expenses of the welfare states is the expenses related to the health. And we decided this, and finally we are here today starting this workshop. From September until April, I think is a short period of time to organize this activity, and I would like especially to recognize the Institute of Self-Government Studies, that your capacity of organization and your collaboration. For us, is also important, and I would like to recognize here especially the role of different persons. The researchers in front of the study of fiscal federalism are Maite Vilalta and Núria Mas, that will be the persons that close this seminary. But probably the person that has organized this activity intensively is, and I would like to recognize this, is Judit Vall. Judit Vall is a woman with a high capacity to do this kind of thing and probably all the things that she wants to propose. And Judit is an expression of collaboration between research centers. Judit started her activity in her research activity. I don't know if I explain this with precision, but this is my opinion. No? Her research activity in the Grèce, that has been mentioned by Joan Ridao as a consequence of one of some last papers published, the papers of Guillem López Casasnovas and collaboration. And Judit started her research related to the health questions. Judit, the history of the public university in Spain is a history of the career, university career, and the possibilities that offer one and another universities. And we have the possibility to incorporate in our department and in our institute the person of Judit Vall. This for us is very important. It's very important because she carries an important activity of research, and it's very important because is a way of collaboration between the Barcelona Economic Institute and the Center of Research of Health Economy that is directed or co-directed by Guillem López Casasnovas, that is here with us today. But additionally, this permits to relate the problem of incomes in the federal or autonomous system, relate this scope and the expenses point of view. No? These questions are not isolated, are very related among them, and for this reason it's very important to do this activity. Finally, I would like to thank again that to be here with us, the minister. The problem of the health, I am not an expert of this, but I attended a meeting yesterday or before yesterday because are here in Spain and in Catalonia in particular in the pre-electoral process. And there are a lot of political presentation of the different point of view. And I attended a meeting yesterday, a meeting with one of the presenters, one of the leaders of the political parties, spoke about probably a traditional activity of the health expenditure that is to forward, to replace the expenditure of 1 year to another years. He precise about 2,400 million of euros these amounts. You don't believe with me after the Minister of Health, that is the real person that can speak about this topic. And the debate was in relation to this sentence that other former important representative of the Catalan government explained that is not a particular situation of the expenditure of the health in Catalonia. This is a tradition during all the years, with some exception, but this is a tradition. As a consequence of this problem is very important. The problem of the expenditure of health as a subject, and logically, the problem of the expenditure of self, this management among decentralized countries. And for us, it's very important. Thank you, Minister, thank you, President, and thank you, all of you, for your presence. Thank you very much.
Good morning, everyone. Thank you very much for being here. And it's a pleasure for me to be here with you, participating today in this interesting workshop about the decentralization and health system. Welcome to Barcelona and welcome to Catalonia, all the participants. It's interesting for me because, first of all, we'll be able to learn about the functioning of the health system in other countries, but above all, from this workshop, we can make known to the rest of Europe how the national health system in Catalonia is, how it works, and what the challenge we have in the system dependent of the Spanish centralism. Agrairé a la Judit Vall i el Joan Costa, que dominen bé el català i l'anglès, que tinguin l'amabilitat després de traslladar a tots els participants les idees bàsiques que vull expressar i que ho faré millor, evidentment, en català. És molt interessant aquest workshop per nosaltres, no? Perquè a Catalunya tenim un sistema descentralitzat de salut de l'estat espanyol des de l'any 81, en el qual es van fer les competències en salut traslladades a les comunitats autònomes. En aquest sentit, el sistema es va articular. A l'any 90 es va definir la Llei d'Ordenació Sanitària de Catalunya, que va permetre l'any 91 la creació del Servei Català de la Salut. Això ha permès tenir un sistema català de salut, un sistema sanitari de prestigi internacional, de gran qualitat, amb reconeixement internacional en moltes de les seves àrees. Tanmateix, aquest sistema té unes mancances i, per altra banda, també té unes oportunitats. La mancança bàsica és que aquest sistema descentralitzat, aquest traspàs de competències, ha estat insuficient. És a dir, no només en el finançament, que segurament serà un motiu avui de debat en aquest workshop, un finançament insuficient en el conjunt de la Generalitat de Catalunya, en el conjunt de l'administració de la Generalitat de Catalunya, però especialment cru en el sistema sanitari. Un sistema infrafinançat durant anys que arrastra any darrere any aquest infrafinançament calculat pels experts amb 5.000 milions d'euros a l'any, que potser a dia d'avui, i segons algun dels darrers articles del professor Guillem López Casasnovas, que ens acompanya, de 3.000 milions. En tot cas, un insuficient finançament que comparativament amb altres comunitats de l'estat espanyol i sobretot amb el conjunt d'Europa ens dona un percentatge d'euros per habitant destinats a la salut absolutament insuficient pel nivell de prestacions que tenim, que necessitem i que la població reclama. Per tant, un insuficient finançament. Però no només això. Aquest traspàs de competències insuficient ho és, per exemple, amb el tema de les prestacions farmacèutiques. És a dir, a dia d'avui, l'Estat decideix una nova teràpia important sobre l'hepatitis C o immunoteràpia amb malalties greus de càncer o malalties autoimmunes, decideix la implementació d'una nova teràpia i no acompanya amb el finançament. Aleshores, la decisió de la nova teràpia no és nostra, és centralitzada, el finançament ha de ser nostre sense el finançament adequat. Amb la qual la situació és incòmoda. Tanmateix, a l'hora de l'ordenació de les professions sanitàries, si nosaltres decidíssim disposar de més formació d'alguna especialitat, tampoc és la nostra competència. És a dir, unes competències insuficients amb una prestació de serveis en la qual tenim competència exclusiva. Aquí hi ha un dels problemes greus del funcionament diari que s'agreugen quan en una situació de pandèmia, això ho vam veure i ho ha dit el president de l'Institut d'Estudis Autonòmics, en l'època Covid, l'Estat decideix centralitzar les compres. Quan la prestació de servei està descentralitzada, decideix comprar de forma unificada. El desastre va ser absolut. El desastre va ser absolut, en una situació caòtica internacional que es va salvar perquè cadascú va adjudicar les compres i es va espavilar, no només cada una de les comunitats autònomes, sinó cada un dels centres hospitalaris. El caos va ser excepcional. Per tant, cada vegada que hi ha un intent de centralització que hi és de forma sistemàtica en un estat que té una tendència centralitzadora i que no ha assumit del tot aquesta percepció federal, no està del tot blindat i genera que la situació grinyola perquè la competència de l'assistència és de la Generalitat de Catalunya. Per tant, aquí tenim el primer dels problemes. Tanmateix, també tenim oportunitats. Tenim l'oportunitat de millorar-ho, naturalment. Millorar aquest finançament, que és una de les reclamacions històriques i que s'ha de produir sí o sí, perquè si no, no podrem tenir un nivell de sostenibilitat. Però, en canvi, també, a nivell de l'estudi comparatiu, en una perspectiva cap a Europa, tenim la possibilitat, en un sistema que a Catalunya l'hem basat en la recerca i la innovació, sent pioners a nivell internacional, a nivell de recerca biomèdica, en el nostre ecosistema que es basa a nivell biomèdic bàsicament amb els grans hospitals i la recerca translacional que ve de les fundacions de recerca vinculades al sistema sanitari i que és de primeríssim nivell, ens permet a nivell europeu ser capdavanters i ser pioners en la manera com podem incorporar aquesta innovació en el sistema. Això no està regulat per l'Estat. Sí que està regulat els fons europeus que tornen a ser centralitzats, però des del punt de vista competitiu, quan Catalunya, en aquest sentit, amb la potència que té des del seu sistema de recerca, és competitiu amb fons europeus, i sortim guanyant. Tenim oportunitat de créixer i d'establir mecanismes d'incorporació de la innovació i de la recerca que no tenen per què estar regulats pel conjunt de l'Estat i ens permeten millorar i avançar. És una oportunitat en la nostra integració en Europa. Segona de les oportunitats, i que les hem d'exercir i les exercim. El model organitzatiu del nostre sistema sanitari i social no està centralitzat. És una competència nostra. Si no sabem fer-ho prou bé, és responsabilitat nostra. I aquí tenim una oportunitat que crec que serà d'anàlisi també de tots vostès interessant, que és l'enfoc que estem fent a dia d'avui al voltant de les xarxes assistencials del nostre sistema de salut. És a dir, els reptes que té la societat avui dia són diversos. Sobretot a Europa és l'envelliment de la població. És l'envelliment amb pacients més grans, pluripatològics, que necessiten un altre model d'atenció. Això ha de fer que la coordinació entre els nivells assistencials sigui molt més alt. No només entre l'atenció primària i l'atenció especialista hospitalària, sinó també la relació entre els diversos nivells d'hospitals i el nivell sociosanitari i el nivell també de salut mental, amb coordinació entre els hospitals bàsics, els hospitals comarcals i els hospitals de referència. Aquest canvi de model assistencial en el qual la permeabilitat dels professionals està per sobre de la mobilitat dels pacients, amb una visió de planificació centralitzada, amb autonomia de gestió, però tanmateix amb coordinació entre els diversos proveïdors sanitaris, perquè el model català és un model ric en proveïdors sanitaris que estan a la xarxa pública, ha de permetre un millor resultat, sobretot en resultats en salut. I això ens porta alhora a avaluar els resultats en salut i no els resultats econòmics a l'hora de finançar aquesta activitat. Per tant, estem en un moment de transició, un moment de repte de canvi de model assistencial que ha de permetre també un altre model de finançament del propi sistema i un altre model de com paguem l'activitat. Aquí hi ha exemples i entre vostès hi ha exemples interessants que crec que valdrà la pena i ho faran segur en aquest workshop de comparar de com es poden finançar també els serveis sanitaris i socials alhora amb un model integrat com el que a dia d'avui estem impulsant des del Govern de Catalunya amb una agència integrada de salut social i sanitària. És a dir, la frontera entre l'atenció social i la sanitària és una frontera difícil de determinar. Quan és una actuació social i quan és una actuació sanitària. L'atenció integrada, el finançament d'aquesta atenció integrada i el pagament d'aquesta atenció integrada que no vagi per acte mèdic sinó que vagi per resultat en salut és el gran repte dels propers anys. Per tant, un model descentralitzat, amb mancances i amb oportunitats, que valdrà la pena en aquest workshop i esperem molt dels seus resultats, de com ho veuen, com es fa en altres països, que sàpiguen també com ho fem aquí, quins són els reptes que tenim i la transformació que estem impulsant a dia d'avui. Per tant, els desitjo molt bona feina i estarem esperant amb delit el resultat dels seus treballs. Moltes gràcies i bon dia.
Thanks. Okay, I'm not going to repeat everything. And thank you all of you for coming here today to hear what we have to say about decentralization in healthcare systems. So the idea was to try to bring people from different origins working on this topic, on decentralization in healthcare, so that they could explain us how this process of decentralization at different levels, and we're going to, each of us is going to talk about different things, but how it works in different settings and what can we learn from these different settings and these different experiences across European countries. So I'm going to be sharing this first table. And the way we have organized both the first and the second one is that each of the speakers is going to be talking for about 15, 18 minutes. So we had some discussions last night over dinner about how much time, but I'm going to try to keep them this is my job today, under 18 minutes, so that we have then time for an open discussion and for you also in the audience to participate. So we're going to start with Caroline Penn, who's coming from the OECD, the Health Division at the OECD. And Caroline is going to make an overview of the work that the Health Division at the OECD has been doing about decentralization across OECD countries. Also, she's going to be touching about measurement issues. How do we measure that? And then finally, I think she's going to zoom in into some specific countries. So she's going to start with these 18 minutes. Then Joan Costafont from LSE is going to follow up. Again, Joan is going to do like an overview, several things, but also like an overview on how or what do we understand by decentralization in healthcare system, how should we think about this topic, and then also zooming in into some of the work that he's been doing on the impacts of decentralization, and then finally talking a bit about what can we learn in terms of decentralization of healthcare systems after the COVID experience, the pandemic experience. Then we're going to be moving to Rita Santos from the University of York, and she's going to talk about a very recent experience in the UK setting on decentralization, but for the GPs in this experience in the UK. And then we're going to end up with Oddvar, who's from the University of Bergen in Norway, who's going to be talking about the Norwegian experience, giving an overview also for this country and what can we learn from this Scandinavian country. So this is the roadmap, and now I'm going to just try to control the speakers that they manage to finish within the 18 minutes that we have given them, so that we have time for discussion afterwards. So Caroline, the floor is yours.
Thank you very much. Thank you very much, Judit, and I'll do my best to try and stay within the time to make your job easier. So like Judit said, my name is Caroline Penn. I'm a health policy researcher from the OECD Health Division, and I was asked today to give an overview of some of the trends in decentralization, looking at different measures that we've developed, and also go through some of the challenges that we've looked at the OECD. So if I could just get the slides up. Great, thank you. Great, so jumping right into it, I'm first going to go through some of the trends in decentralization across OECD member countries. So the first measure I want to look at is comparing health to other sectors of government. So here on this graph, you can see subnational government by sector, using the COFOG approach, which is the classification or function of government, which breaks down public spending into different policy areas. You see health there on the bottom, which is the light pink bar, and the OECD average in there, which shows about in 2020, 14% of government budgets were dedicated to health. Of course, there is big variation in this range, where you see countries such as Italy, where over 50% of the subnational government budget was dedicated to health in 2020, all the way to the other end, where you see countries such as Iceland, Italy, Ireland, where around 0% of the subnational government budget was dedicated to health. Zooming in now on this OECD average, again, this shows subnational government by sector using the is that better? Yeah. Using the, again, the COFOG approach. And so this shows the OECD average for 2020, but also for 2010. And as I said in the last slide, health made up 14% of subnational government budgets in 2020, and this was the fourth largest decentralized policy area. You can see that education makes up the largest decentralized policy area, followed by social protection, and then we have economic affairs just above health sector. Looking over time, you can see the share has remained fairly stable, with just a 1% percentage point increase between 2010 and 2020, meaning that it has become a slightly more decentralized policy area over the last decade. So now just looking at the health sector, an important measure of decentralization is subnational government spending in health as a share of total expenditure. And this is shown on the graph here for the years 2010, 2019, and 2020. And you can see on average the blue, which is the OECD average for the data, for the countries we have available data, around a third of health spending came from subnational government budgets in 2020. Again, there is big variation where subnational governments funded nearly 100% of healthcare in countries such as Denmark, Italy, and Sweden, to again the other end of the spectrum where subnational governments funded around 0% in countries such as Greece, Ireland, and Israel. We can also look at the trend over time from this graph. We saw that in 2020 there was a bit of a shift in decentralization due to COVID, where the central government assumed a major role for financing COVID response measures. Therefore, looking between 2010 and 2019, we saw that the share of subnational government spending in health decreased by about 0.5 percentage point, so it actually decreased over this period. However, there is quite a few outliers in this data. You can see Hungary being one of those outliers that is skewing the OECD average. That if we look at specific countries, we can see that the share of subnational government spending increased in 17 countries, where the share of subnational government spending decreased in 12, and it stayed around the same in about 3 OECD countries. So therefore, for more countries, the share of subnational government spending has increased in total health expenditure over the last 10 years. So while we know that spending shares is an important measure of decentralization, we know that there are significant barriers on the decision-making ability of subnational governments. Therefore, at the OECD, we've undertaken work to try and better understand subnational government decision-making power in the health sector, looking beyond simple expenditure shares. And to do this, we've surveyed our countries asking which levels of government are responsible for certain key healthcare decisions. So key decisions surrounding the policy, around budget, around inputs, and I'll talk through those in a bit in my next slide. But this slide shows an overview of the allocations of decisions across levels of government. So you can see the central government, which is the dark purple bar, still has strong responsibility for decisions in the healthcare sector. They are twice as more likely to be responsible for decisions than the regional governments, and 4 times as likely to be responsible for healthcare decisions than local governments. And like I just mentioned, we categorize healthcare decisions into 4 areas of autonomy. The first one being policy decisions, so who's making decisions around health policy objectives, for example, or setting national standards and regulations. We also looked at decisions around the budget, so who's setting the budgets and determining the allocation across regions or service providers. We looked at input decisions, so decisions on staffing or infrastructure, for example. And we also looked at decisions around outputs and decisions on the monitoring mechanisms for healthcare sector. And this graph shows the responsibility across these different areas of policy autonomy, of spending autonomy. So you can see that central governments have most decision-making power for policy and budgetary decisions, whereas they have less responsibility for input decisions and also output and monitoring. In contrast, regional governments are more likely to be responsible for decisions around inputs, such as staffing. And as we saw, local governments have little responsibility in the healthcare sector, but have most responsibility, again, for inputs, such as hospital infrastructure planning. So putting this all together, this graph shows the 2 indicators that I've just talked through. So the subnational government expenditure as a share of total expenditure, which is the blue dot there, against subnational responsibility as we calculated responsibility for key healthcare decisions. As you can see, for most countries, the share of subnational government expenditure is far greater than the subnational government responsibility, suggesting that subnational governments have many barriers in their decision-making power, and that simply looking at expenditure shares may overestimate the level of decentralization in the healthcare sector. So now I've gone through the main trends. I now want to go through some of the challenges that we've come across in regards to decentralization across our member countries. And one of the key questions in decentralization relates to how decentralization affects health system performance. And to try and understand this relationship, in 2019 we carried out analysis looking at the effect of decentralization on health expenditure and population life expectancy as measures of performance. To do this, we constructed a decentralization indicator based on responsibility for key healthcare decisions, like I just showed you, and we constructed an indicator from 0 to 6, with 0 being fully centralized to 6 being the most decentralized. The graph here shows the analysis of the results, and we call this our fish graph, and hope you can see why. On the left-hand side, we have expenditure. On the right-hand side, we have life expectancy, and along the horizontal axis is a decentralization index. And we found a statistically significant result both on life expectancy and expenditure, and we saw that decentralization, as we move across the horizontal axis, both decreases health expenditure and increases life expectancy. However, you can also see there is a turning point where there's excessive decentralization, which causes an increase in expenditure and a decrease in life expectancy. Another key challenge I want to mention, and this was discussed in some of our opening remarks this morning, was about the fiscal sustainability of our health systems. As we know, OECD countries are going through the impact of population aging, which both affects the demand for healthcare services and their revenue-raising ability. And as we know, health is decentralized in many countries, so therefore we wanted to better understand the impact of population aging on the fiscal sustainability across levels of government. So to do this, we first projected health expenditure and revenue to 2040, and health expenditure is plotted along the horizontal axis, and revenue growth is projected along the y-axis. And you can see that dotted line there on both of the panels represents equal growth in health expenditure and revenues. Panel A is for central governments and social security funds, while panel B is for subnational governments. And you can see through to 2040, for virtually all OECD countries, the growth in health expenditure is greater than the growth in revenues, except for Australia. For central governments, you can see it just falls on the dotted line, meaning equal growth. For subnational governments, again, health expenditure growth is projected to be greater than revenue growth for virtually all subnational governments, with a few exceptions. You can see Belgium, Slovakia just above the dotted line. This means that the health expenditure to revenue ratio will increase for virtually all OECD countries across all levels of government in the next decades. However, we wanted to explore this relationship further, and to do this, we plotted the increase in the health expenditure to revenue ratio for OECD countries. Along the x-axis, this is the health expenditure increase for central governments and social security funds, and for the y-axis, this is for subnational governments, and this is plotting the health expenditure to revenue increase that we saw on the previous slide. We have two different assumptions for revenue buoyancy, hence the two different panels. And by plotting these countries according to the increase in the health expenditure to revenue ratio for central and subnational governments, we can assess the likely impact. Looking at the top quadrant, this is where both levels of government see high increases in the health expenditure to revenue ratio. Looking at the bottom left quadrant for both panels, this is where neither subnational or central government will see large increases in the health expenditure to revenue ratio. Looking at the top left panel, this is where subnational governments will see a relatively greater increase in their health expenditure to revenue ratio, where the bottom right quadrant is where central governments are expected to see a relatively higher increase in the health expenditure to revenue ratio. And you can see that for both quadrants, the majority of countries fall in the bottom right quadrant, meaning that it's the central governments that will see the most fiscal pressures associated with population ageing. This can be explained by two factors. The first one being that central government revenues are more likely to be impacted by population ageing, as they rely on revenues such as personal income tax or social security contributions. Secondly, as we saw that while subnational governments are responsible for about a third of health expenditure, central governments still have responsibility for 2/3 of that expenditure. Nevertheless, there are important exceptions. You can see countries in the top left quadrant, such as Denmark, Finland, Italy, Spain, Sweden, and Switzerland, where the subnational governments will see the pressures of population ageing and will see higher increases in their health expenditure to revenue ratio compared to central governments. This is particularly challenging as we know that subnational governments have relatively less autonomy over their revenue-raising ability, as they can rely more on intergovernment transfers, they might have borrowing constraints, or we see they have limited decision-making over their budgets, as we saw from the previous analysis. So there's many more challenges that I could talk about today, but I just want to finish by providing the example of a country that we've been working closely with recently, which is New Zealand. And this example illustrates quite nicely some of the other challenges faced by decentralization. So New Zealand is going through a massive reform of their health system at the moment, and this slide shows the old system. You can see their health system was organized around 20 district health boards that were defined by their geographical region and responsible for the delivery of health services and for around 75% of health expenditure. The funding for each district health board was determined by a population-based formula that was adjusted to various factors that accounted for the different costs of providing care for different population groups. So there was a big 2020 review of their health system that identified a range of challenges. The first one being huge variation in clinical performance, large inequities in health outcomes, especially for their Maori indigenous population. They also found a situation of a postcode lottery where the quality of care depended on where you lived. Their system was found to be very complex. There was the 20 district health boards for a relatively small population in New Zealand, meaning that for some their geographical area was very small. There was also duplication of structures, analysis and bureaucracy. They also had large financial problems. Nearly all, I think 19 out of 20 of the district health boards were actually in deficit, and there was large variation in their fiscal management practices. The population-based funding formula also caused large variation in their funding. And finally, governance. There was limited qualified people to govern the 20 district health boards, and these governed people were often elected in local elections, but there was very low turnout for these elections, meaning there were questions in which the actual leaders reflected local priorities. As such, in 2020, New Zealand completely reformed their health system. They've now got a new centralised national health system. They completely disestablished the 20 district health boards. They created a new organisation, Health New Zealand, which is leading the overall organisation of health services. And alongside that, they have the Maori Health Authority, which is ensuring quality of care for the indigenous population. So I think it's a good example of a country going through a recent reorganisation, and definitely one to look out for how this goes for them. So just to conclude on some of the main messages that I've spoken on today, we saw from the health expenditure data that there was a slight trend towards decentralisation over the last decade. However, looking at decision-making power, it looks like significant decision-making power still rests with the central government, suggesting they still see it as their belief to ensure the delivery of efficient and equitable health systems. We saw by looking at the relationship between decentralization and performance that a moderate degree of decentralization can reduce health expenditure and increase life expectancy compared to a situation of very low decentralization. And also we looked at the population aging challenge associated with the fiscal pressures associated with population aging. And although we saw that central governments are at the forefront of this challenge, where subnational governments face fiscal pressures, this is a big issue as they often have limited revenue-raising capacity. So that's all for me, and I'll pass back to Judit. Thank you very much.
Thank you very much, Caroline. Amazing time management. It was exactly 18 minutes, so here is your challenge now.
Great. Can I get the clicker? Lovely. Great. So, waiting for the slides. Oh, yeah.
No, aquí.
Great. Great. So, thanks so much to the organizers of the workshop, everyone here. Appreciate that, and particularly Judit for such an efficient organization. I mean, we just heard like a month ago, and literally, you know, like all this has been done literally in no time. So what I'm trying to convey today is basically a talk on decentralization in tax-funded health systems, right? So we could discuss decentralization in other kinds of health systems, but I'm going to focus only on NHS kind of systems, and that would mean particularly a bit of an overview. So what I'll try to do is a bit of a snapshot of different papers actually that we've been writing throughout the years with some of you. I mean, with Guillem and with Gilberto, and I'm not sure whether I have more co-authors in the room, and Joan is there. But you know, I'll just give a bit of an overview of different bits and pieces. And I guess that we should start by so a little bit of self-promotion. So I'm going to show like some snapshots of books that we've written. So there is a book on federalism in Europe, and it's in health and social care. So the first question is, I guess, what do we mean by decentralization? And you'll see that in the literature there is a bit of confusion, and people define decentralization as the decentralization of organizations. And I think it's very important to clear the concept and say, you know, decentralization just means sharing the stewardship of the health system. So the governance of the health system gets shared between different layers of government, right? So it's vertical power sharing. So that's what decentralization means, or that's what I refer as decentralization. And when that decentralization is, let's say, included and constitutionally defined, then we refer to that as federalism. So federalism just means that you own a responsibility. So Catalonia in this case would own a responsibility, and the central government could not necessarily, or could not legally then rule over. And it's important to distinguish the power to tax, which is what we call fiscal accountability, or fiscal decentralization, and political decentralization, which is the power to regulate and spend. And they should go hand in hand. I mean, in principle, what we've heard, actually, Joan Ridao was mentioning, and we've heard before as well, looking at OECD data, that there is a bit of an imbalance between the responsibilities that are allocated, let's say, to Catalonia. The minister was referring to the fact that Catalonia is basically receiving lots of responsibilities, but very little funding for those responsibilities. So that's what we refer as vertical fiscal imbalances, right? So we are facing huge imbalances, vertical imbalances. And the question is how to sort it out. I mean, we need, Spain now is thinking of redefining its regional financing system, right? So the question then, once we've defined decentralization, is why do we decentralize? We decentralize primarily for a number of reasons. Decentralization in that case would mean matching the scope of government with, let's say, its resources, and the reasons to decentralize have to do with the fact that preferences are heterogeneous across the territory, and needs as well, particularly in healthcare, needs are very different. So some parts of, let's say, if you look at Spain, some regions in Spain, they have more older people, and some would have more children. So it wouldn't make sense to run that centrally, because there would be differences in needs across the territory. So it would be very inefficient to centralize healthcare, right? And that's why we decentralize, because it's more efficient. There are preferences and needs that are heterogeneous. Information, I mean, Hayek was an LSE professor back in time. Argument was that information is always spread across the world, right? So if you centralize, you're missing out. So he was very much against planning because of that. On top of that, you could argue, and that's part of our research, that there is a lot of policy innovation going on. When it comes to healthcare, healthcare is a responsibility that is constantly innovation is constantly happening, right? So if you decentralize, you're creating a laboratory of experiences where we can learn from. Whilst when you centralize, that laboratory of experiences is harder to take place, right? And what happens, at least in Spain, is that some regions innovate, even very poor regions that are not very well resourced, like Extremadura, for instance, these days, are front runners in some fronts, right? So decentralization allows for some regions actually to innovate and others to copy. And that's why, I will show in a minute, decentralization actually reduces regional inequalities against the sort of convention that decentralization would increase diversity in the system. What we are finding is the opposite. Decentralization reduces diversity in the system because it allows some regions to perhaps do better in the short run, but the others immediately copy. And you're copying from the best. You're not copying what doesn't work. You copy what works, right? Now, why would countries not? Why don't we see all countries decentralizing the health system? So that's the next question, and that's because decentralization entails some economies, losing economies of scale. So we see that decentralization entails increasing slightly, like some fixed costs on the health system, right? So small countries you could name a few in Europe, they might not decentralize because of that. Another reason not to decentralize a particular function is because there might be spillovers. So it could be that if you decentralize, let's say, the pricing of pharmaceuticals, then the pricing in Catalonia would affect the drugs in, let's say, Andalusia or elsewhere in Spain, and that would be inefficient. That's what we call a spillover, right? And I will argue that actually many responsibilities that now are run by the nation states in Europe should be scaled up at the European level. So there is scope now for the creation of a European health union. Right, so Europe has very little power when it comes to health policy, and actually I would argue that there is a scope for expanding that responsibility. Great, so that's what I meant by defining decentralization. Now, decentralization is typically a joint responsibility. I don't think we need to say much about this. I mean, this is just evidence from a number of Eastern European countries, just to take countries that we are not used to hear about, and most of them, the healthcare is shared between different levels of government. So clearly, healthcare is an area where there is shared responsibility. Now, conceptually, the way I think about decentralization is that we are all patient citizens. So we pay taxes and in NHS, and at the same time, we are potential patients, right? And because in an NHS system, we don't pay for healthcare because healthcare is free at the point of use, then the reason why we choose one provider or another is purely based on quality, right? So expenditure, it's of course a function of quality. The higher the quality, the more we expend, right? And the idea is that the patient citizen makes choices based on that quality, right? And what we know from the fiscal federalism literature is that individuals have two choices, typically either to vote with their feet, so literally move to those areas that provide better quality of care, right? Or simply support the political party that happens to deliver that quality of care. So you can either vote, you can vote with voting, with your electoral vote, or vote with your feet, moving to some other region, right? And that can happen horizontally. So what happens is that some responsibilities might be better run in the Balearics than in the Balearics than in Catalonia, and the weather is very similar, so why not moving to the Balearics then, right? So that would be one way of sorting out the problem. The other is, if you see that in the Balearics they are doing very well on a particular front, what you do is you vote the party that is proposing that policy that is successful in the Balearics, right? So the political agency is what gets the fiscal federalism to act like a market, right? And that's why many economists are so excited about fiscal federalism, because we are actually introducing some market mechanisms within the government, right? Now, let me just state a few facts, because I won't have time to go into any detail, but what I was saying before, that decentralization doesn't reduce inequalities speaks to the question on whether it affects spending. It's true that decentralization and federalism more generally increases spending, but not dramatic. The difference is not dramatic, right? And one of the concerns looking at the US evidence is what the so-called race to the bottom. So if you look at, let's say, some concerns from, let's say, the extreme left, kind of criticisms to decentralization is that, oh, you know, this is a form of privatization. Well, not really. In fact, what we see is that when you decentralize, expenditure increases, right? So it's clear, there's clearly no race to the bottom because the competition here is, particularly on NHS systems, is on quality, right? So the competition is on quality, which basically what it does is it increases spending as opposed to the opposite. I mean, there's, of course, other reasons why we don't see a race to the bottom that we probably don't have. I mean, I listed them there, but we don't have the time to go over them. Now, just some examples of how policy, innovation, and diffusion happen. So, for instance, this is an extract from a table in one paper that we published like 15 years ago. And so this refers to some policies that were introduced, let's say, in Catalonia, the integration of health and social care. So the minister was actually referring to this. This was something that already happened in 1986, and actually a number of regions copied Catalonia. Or, for instance, the Canary Islands introduced the right to the second opinion, right? And this was introduced in the Canary Islands and then copied by Andalusia and other regions. So a federal system introduces dynamism and allows for policy innovation and diffusion. And I would argue that this explains why regional inequalities don't increase. Now, another reason why we don't see a race to the bottom, and this is more self-promotion on a recent book on political economy of healthcare, with chapter 2 with Gilberto, and chapter 2 actually touches upon decentralization. So it's important to distinguish Europe and the US. The US, the default system, is one where there's no welfare state. So federalism is very much something defended by those that want to harm the welfare state. Federalism is an impediment to the development of the welfare state in the US. But in Europe, it's the opposite. In Europe, our default is a welfare state. So federalism, what it does is that it's a veto, let's say a barrier for those that want to actually weaken the welfare state. Right? I think that's something to keep in mind. So. And I won't say much. Here is some evidence that actually inequalities, green is Spain, you see inequalities, I mean, the data is very outdated, fortunately, but this was the time where decentralization was introduced or extended to all regions in Spain. Decentralization reduced regional inequalities in Spain. We don't see the same in England. England is the most centralized country in Europe, together with France, right? It's one of the most. Interestingly, not the UK, because of course the UK includes Scotland and Wales and Northern Ireland. And if we look at the UK, you see a little bit of a reduction. In England, it's more or less flat, so nothing happens. So that's evidence, I would argue, that when you don't decentralize, when you keep the health system uniform and the same across the board, then inequalities, regional inequalities persist over time, whilst when you decentralize, those inequalities actually drop. Now, this is a paper that we published recently with Ada Ferrer, who's the president, I think, of the Catalan Economic Society, I think it's called. So this basically, we argue there that, I mean, one of the differences between, let's say, health and other responsibilities is that there is a private sector in health, right? In Catalonia, we have the private sector is integrated in the public health network, but that's not the case across the board, and even in Catalonia, there are like independent providers. And what we show in this paper is that when you decentralization does very similar thing as the market does. So you're providing the middle class with an alternative to going private. When you decentralize, middle class people, rather than taking up private insurance or simply going private, they stay in the public network. Right? And because they stay, they push, they are often very pushy, and they get the public network to improve over time. Right? And that's what we show in this paper. This is just like some evidence that, for instance, when you decentralize the health system in Spain, the perception of the public system improves by 7 percentage points. It increases the preference for public health care in 12 percentage points, almost 11% increase in the satisfaction with the public network. And if you focus on the high-income people, or middle-class people, they are less likely to go private, right? Now, just before I finish, let me just switch to Europe, right? So we've been talking about decentralizing down to the, let's say, subcentral units, but what about Europe, right? So Europe is quite, it has huge imbalances. I mean, Europe, we're talking about Catalonia having huge imbalances between spending and responsibilities. Well, Europe is even worse. I mean, the total budget of the European Union is 1% of GDP, so it is completely ridiculous, right? So how come Europe doesn't have actually more responsibilities, more, particularly when it comes to healthcare? Because there are, for instance, the pandemic has illustrated large spillover effects. So, for instance, lockdowns in Spain have saved lives in France, or lockdowns in France have saved lives in Germany. And right now in Europe, we don't have a European, let's say, we have a European ECDC, the European Center for Disease Control, but it doesn't have any executive responsibilities, unlike in the US, right? So I guess that the next step when it comes to policy making, and I'm not just the only one actually advocating for this, is to actually push for a European health union. And the evidence seems to be backing it. I'll just show a snapshot of a paper that we're working on. And then another point to make is that when we know nothing about the health system, which was what happened in the first wave of the COVID-19 pandemic, and Joan Ridao referred to it, centralizing the health system is a disaster. Because what you want when you have a pandemic is to experiment and make use of the local expertise. If you don't do that, then more deaths will happen, right? And that's what we did in a paper with Gilberto. I'm going to show it in a minute. This is just like large evidence of differences in policies across Europe. I mean, I'm not sure you can read very well what's going on, but you have curfew, social distancing, restrictions in mass gatherings. There were European countries, they were zero aligned, as you can see. I mean, each country will do its own thing, right? And what we did, this is a regression analysis, I don't expect you to understand it, but what we are trying to do is looking at how, let's say the deaths and the COVID cases in one country were affected, not just by the policies in the own country, but policies in the neighboring country. And what we show is significant evidence that, let's say, a lockdown in a country had saved life in the neighboring country. And that's evidence of a policy spillover, which basically suggests that we should actually have a European health union. I mean, we can discuss that later. This is just like a snapshot of a regression that, we have done a few of those, and we are working on this. Hopefully, we'll have some impact. But then, I will finish off with this paper that just shows the opposite, that when we know very little about the pandemic, about the virus, what we should do is to keep the health system decentralized. Because, and that's what Italy did, because in Italy, the Italian constitution doesn't allow a state of emergency. It's not in their constitution, whereas in Spain, we do allow it. And what happened here is that Spain declared a state of emergency, centralized, let's say, healthcare security, right? And because of that, we didn't experiment enough, and we didn't allow regions to perhaps be a bit more ambitious when it came to restrictions during COVID. So, for instance, in Italy, Lazio had obligatory compulsory flu vaccinations, or Le Marche, for instance, closed educational institutions, right? And what we show is that because of that, and that's a paper published last year in Publius, which is this Journal of Federalism, we show that actually, if you look at the number of deaths or patients admitted to hospital, in any indicator that you look at, Italy does better than Spain, right? And we argue that at least in this period, which was the first wave of the COVID pandemic, that has to do with the fact that Spain ridiculously centralized healthcare without any particular argument. That was a bad idea. And in fact, they even recognized it later on because they moved very quickly to a model of co-governance. So tentative conclusions. So I am of the view that rather than thinking about centralization and decentralization, we should think about functions. So some functions should be actually centralized, as I was arguing for the European Health Union, right? But for some other functions, we should go the other way around. So I think that we should move on from the classical debate of centralization, decentralization. Things are not binary here, right? And I think that this is quite important. But we know that decentralization doesn't increase inequalities, and if it does anything, it creates a race to the top, not a race to the bottom. And the reason why we see a race to the top is because competition in national health systems is based on quality, right? And finally, when it comes to a pandemic, if there is a pandemic in the future, I think that we would be better protected if we had a European health union. So if we had some responsibilities at the European level and we could close, let's say, the common market to protect Europeans against a threat. So I'll stop there. Thank you.
Thank you, Joan, very interesting also. And you're making my job very, very easy. So, Rita, the floor is you with the challenge of the 18 minutes.
Well, that would be a nice challenge. And Joan did some work for me as well, because you already told about competition and quality, and so, you know, thank you. So, my presentation is much more focused. I'm going just to give you an example in terms of primary care in England. And I title it as Primary Care Collaboration versus Competition, since it's kind of before-after decentralization. So this is the usual disclaimer, just to say none of the views expressed as from the funder is my own, so blame me, don't blame the funder or Department of Health and Social Care. So what is the rationale on starting to work towards primary care, comparing competition and collaboration? The rationale was the change of the framework from the English primary care market from competition to collaborating. So we have a new reform in 2022 with introduction of the integrated care systems, and they were really to encourage the collaboration of primary care providers and also with all the other organizations. So instead of we having providers providing primary, secondary, community care, what integrated care systems want to do is integration of those services, so better patient flow across them for within the system. So providing more and better patient care by having a better flow through the system of the patient and adequate need. So this was also simultaneously a further decentralization of primary care funding. So these integrated care systems are composed by integrated care boards and integrated care partnerships, and the boards are the one now responsible for planning and funding of GPs, hospitals, and other providers. As I said, this is the reorganization of 2022. We had some before. So if we go back to 2001, we had the primary care trusts, and they had some of the commissioning of primary care, and they were 303. Then we thought it would be better to have bigger areas. So we had a reorganization in 2006 to 152. And then we thought to get GPs to lead the local health authorities. But we took out the primary care commissioning since there was GP-led. And we started with 211, but by 2021, there were only 106. Since financially it was very challenging to have so many local health authorities. And now we have the 42 integrated board systems, and we do have this decentralization of the primary care funding. And again, a big incentives on collaboration versus competition. So what we know as well is that the organizations before, they didn't achieve one of the most challenging, and again, Joan did a bit of help there already, that there is no change in terms of the overall variation of the regional inequality. So we see this over and over again, even after so many reorganizations. We still have the red where there is worse provision in terms of quality of care, and is very similar to the income deprivation map as well. So what we had before 2022 and before 2017, we had in terms of funding, NHS giving a block fund to CCGs that would be commissioning and funding other providers, but not primary care. And NHS England was responsible for commissioning and funding GP practices, so primary care. As anything, it doesn't happen overnight, so over the years, there's been talks, and CCGs were getting more and more involved in commissioning primary care, but not all of them. So some were in pilots, and then in 2017, some of them were responsible for part of the commissioning, so they would be, responsible for the funding or not. But now we know in 2022 that these ICBs, these 42 areas, are the ones responsible for commissioning primary care. And we also know that this decentralization is based on collaboration, so trying to give incentives that is collaboration within these areas. And we have elements of things as primary care networks to help that. So for them to share services and workforce. So the funding is slightly different. It's not just for one single provider. Now we are also funding networks so they can work better together and find ways to provide for bigger areas. What does the literature say? So we did find a competition on quality, since we were in a fixed price market, did increase quality, but very, very small amount of increases. We also know that this push to have bigger primary care providers is not actually providing better care. So we have a decrease on the patient satisfaction and other clinical. And when we start having these collaborations and these cooperations, we also see that it's not equal. So in some areas they work quite well because things have been happening before, but in the most deprived areas it's quite difficult to get these collaborations working and working well towards the population. So what I'm going to show you now quickly is what we found on the competition and quality. So why would practices compete? So in terms of quality, it's because the funding they receive is based on the number of patients. So you can see by this very simple graph how the practices get funded, and you can see the bigger area it is on capitation. So more patients means more funding, and you do need the funding to provide care. So that's why there is competition for patients. There was some also literature on cream schemes, so do you want to attract the most healthier and easier patients to treat? But that's why there is competition on the GP practice market, and also because there's an overlap of the catchment areas. So when we investigated this, we had some data over the years on all the private primary care providers. We did the competition measure and we look at quality. And we did find that there was small increases on the quality once there is more competitive, but there is very small adjustments. What can we find now with the collaboration and funding? So we are starting to look at this because it's quite recent policy. So we're going to focus really is how these practices of primary care providers have been collaborating over the years, how mature is this collaboration, if it does have an impact. So we're going really to look as, for example, on the funding area, since we know that all the practices had to join these networks, these primary care networks, because they wanted to cover bigger areas, so 35,000 to 50,000 patients. We also have the experience that it's not that easy to scale up. So how do these to improve patient outcome? The other thing is that how can we do these reorganizations towards better healthcare? And the way it was possible was changing the contracts. Again, the finance and the funding is really the engine of these collaborations. So if you want a practice to do more collaboration, you have to put the funding on the collaboration, so they will stop looking at just the amount of patients and competing for patients, and actually looking at how can I get more funding through these collaborations. So this is how we're going to look. As I said, nothing happens uniquely in 1 year. So before we have these formal networks, there are already some joint provision of some services through something called federations. So one of the things that practices were asked a while ago was to provide extended hours. So this means that primary care would be open after 6 p.m. until 8:30, and it will open slightly before from 6 a.m. to 8 a.m. This is to allow access of patients that cannot go during working hours and trying to relieve the pressure we had on our emergency care services. What happened is that practices felt that it was quite difficult since they have quite challenges to get workforce, so more GPs and more nurses to provide these extended hours. So they start collaborating through these federations, and they start providing for all the patients of several practices through these federations. So the collaboration started with providing very targeted services to the population. And this started with something called federations. Why do I talk about this? Because this is how, while they have very distinct organizations with very different contracts, they start collaborating. So these is things that we need to understand in terms of maturity of the collaboration. So it's not just decentralizing the fact that now is more local primary care funding decisions, but also understand how to provide this collaboration and how to start making practices talk to each other and start collaborating on services and patients. Even on IT systems, it sounds easier than sometimes it is. So we're going to look not just at the PCN, so these network, these formal patient primary care networks, but also the federations and how they were already in conversations or collaborating, even through COVID, but it started with this extended hours access. So this is just to prove that I'm an academic. I need to put a formula somewhere. But it is to say that we're going to distinguish basically practices that have been collaborating for longer through these federations before the primary care networks, and the other ones that never collaborated before, so it's new to them to start collaborating with other practices, because that will be different. We're going to test the collaboration on funding, since that is the real engine. So if they got more funding for collaborating better and more, and they have more mature relationships, these will be the engine to say, okay, and now what are you going to do with this funding? Since this network is working for your funding, is it working as well for the patients, for their quality of care? So that's what we're going to look. So we're going to look at data from the introduction of these networks. It's 2019, so we only have 4 points of data. And hopefully this will inform us of what can we expect from the decentralization, since it's just happened. So usually we are asked, so what you think it was the impact of decentralization? And you feel, but it just happened, how do you want me to see the impact? It's just 1 year, and it was a transitional year. So we need to find somehow to understand and predict what can this happen, or what these collaborations can bring forward. So we did on the workforce, so we look at the type of workforce that primary care usually has, so not just the family doctor, but also the nurses and everyone else involved, the patients, so the demographics, the prevention, disease, so the complexity that these practices face in terms of their patients, and then the funding, not just the total pay, but also from the pay for performance schemes, and for other ones like the extended access, since we know that this was one of the early collaboration mechanisms. So very briefly, the results is that if you have stronger network, you usually get more funding. So you are able to have better funding, probably because this collaboration will help you to look for the better pots of money and how to access those. Because sometimes you might be eligible, but you don't know how to access these fundings. In terms of workforce, which these PCNs were meant to, and this decentralization is meant to, it will help practices to get workforce, because it's one of the struggles at the moment, is not the same. So the ones that didn't know each other, actually are doing a better job than the ones that were working already together. So this is just to show that it is ongoing. We start reorganizing in 2001, 2006, they are organized. We have introduction of collaborations. Then we have introduction of GP-led, which allowed not for commissioning primary care. Then they were starting to have some commissioning of primary care. And then they joined these collaborations, these formal collaboration networks. And now we have the decentralization of primary care funding. So what can we expect that happens? We know that the funding is getting stronger for the ones that have more mature collaborations, but what can we expect, not just in terms of quality of care, but actually on inequality of access? So can we expect that these collaborations will bring and narrow, finally, some of this unwarranted variation across England? And that's me.
Perfect, thanks, Rita. So we move now to Norway. Oddvar, the floor is yours.
Thank you. So let's see if I have to watch to see when I have 18 minutes. You're perfect. So let's see if we can get the slides up. So I'm Oddvar from the University of Bergen. And yeah, I don't know how much you know about Norway, and what I think is important when you talk about the health sector, you have to understand the context that the health sector works in. So I'm going to tell you something about Norway, and then go more into the healthcare sector and decentralization. So Norway is a relatively large country. It's not so large as Spain, but it's not only a relatively large country, but we have a very little population. So like only 5.4 million people live in Norway, and they live all over Norway. And Norway is also a very long country, so if you turn Norway around on the southernmost axis, you will get to Rome. So you know, we have half the population of Greater London, and this very, very big area. So in some sense, you know, you have to think that, well, things must be decentralized. We have 3 levels of government: the state, the countries, and the municipalities. And Caroline, you were talking about, you know, the small health boards in New Zealand with 50,000 people. But you see that we have 357 municipalities, and 35% of them has less than 3,000 inhabitants. And the municipalities are responsible for primary care in Norway. So there's a really, really small populations. We have people live very, very decentralized, and we are very concerned about equity and fairness. And I'm not sure I follow completely your analysis that decentralization is a way to make sure that you get equity and good service, quality of your services. So in Norway there is this trade-off that we want to have people live very, very decentralized. We accept that, and at the same time we don't want to have any inequity. So that's a big issue. Luckily, we are a very rich country. You know, if you look at the GDP per capita, this is adjusted by purchasing power. We have almost $80,000 per capita. In Spain, it's like $49,000. This is adjusted for purchasing power. And we have this very big oil fund, about 1,500 billion euros, and the expected net present value of the oil that we know are there that we haven't started exploited is 1,000 billion euros. So it's like that. So we have a lot of money. So you can think that looking at Norway, you will see that money cannot solve all problems. So what about then the Norwegian healthcare system? Well, we call it semi-decentralized. So primary care and long-term care are the responsibilities of the municipalities. GPs are mostly self-employed and contract with a municipality. So that's the decentralized part. When it comes to hospital care, that's centralized to the central government. So hospital care is the responsibility of the central government, and it's organized through 4 regional health authorities. And the boards of these regional health authorities, they are not political. So they are appointed. So I am the vice chair of the board of Health Region West, and I'm appointed by the Minister of Health, Of course, people in the board will have like the competence to, or should have the competence to understand the political things that goes on, but we are not a political body. Hospitals are organized as independent trusts with their own boards. So we have this like split, and if you were looking at Caroline's numbers, you saw that like in Norway, like 30% of the funding was in the subnational levels. For example, compared to Sweden and Denmark, which was like 100%. So it's also easy to think that the Scandinavian countries are quite similar, but they are not. And this also means that the municipalities that are responsible for primary care and contract with these GPs, they have very, very little freedom to choose their own taxes. So taxes are centrally determined, money are collected into the central government, and then there is like a formula that reallocate the money back to the municipalities, and the municipalities then basically have to use this money to provide these services. And for example, for long-term care institutions, that will basically cover or are responsible for like 1/3 of the total running cost in the municipalities. Yeah. Most services in the healthcare sector, both when it comes to the payment of the GP and payment of hospital, is like a mix of various type of activity-based funding and block grants. There is a trend of more and more block grants being used. Co-payment is very low, except for nursing homes. There you have to pay co-payment based on your income. And so rationing is by waiting time, because in all systems, demand for healthcare is larger than the supply. So we have an issue with long waiting times. When it comes to priority setting, well, it's cost effectiveness and severity. So that's like the structure of the healthcare sector. We have some choice, so we can vote with the feet. Patients can choose hospitals, and citizens are allowed to switch GP twice a year. The problem is that there is basically, we have like a list system for the GPs, and basically all lists are filled up. So if I want to change it to a new GP, I have to be waiting for the GP to either accept that more people should be included in the list, which is not happening, or if somebody dies or move away, so there is like a free slot. So there are some choice, but mainly when it comes to the choice of hospital. We are doing quite good. These are just some results from different rankings. Typically, we do better than most other countries, but we typically also don't do very well when it comes to the way we follow up people with chronic condition, the way we are able to keep people that should be kept out of hospitals, and we also have a lot of overdose deaths. So there are some challenges, and these challenges are in some sense related to the way we have set up the system, where we have like a two-layer system. We have like the municipalities that are responsible for primary care, and we have the central government, which is responsible for hospital care. But what we see, people get older, people have like many chronic conditions, so the pathways is going really between these two layers, and that creates a lot of coordination problems, which I think is what we see when we come to see at these overviews of performance. Yeah, we are a rich country, and we use a lot of resources on health. These are just some numbers. So we use a lot more on health than the OECD average. Most of the healthcare is provided by the government. And as Caroline said, we are having this problem that the growth in the real expenditure is in the healthcare sector is larger than the growth of the GDP. So we have some issues, but we have this like oil fund that we can use to subsidize or to solve these monetary issues. But still, you know, we don't want to end up with the Dutch disease, so we have all these more like these macroeconomic conditions that hinder us to solve problems with just like putting more money into the system. If you look at so where do I go back? No. If you look at the employment, so if you include the social sector, then about like 21% of the employment is in the health and the social sector. That's a lot. If you only look at the health sector, it's about 15%. So this graph basically shows that we have more doctors and more nurses than many other countries. And well, this is, of course, we have a decentralized system. You know, people live very decentralized. They live in these rural municipalities. They should also have the services. So then you need to have the healthcare workers working there. But it also creates a problem because, you know, all the other sectors in Norway also needs more people. So if you want to have a job, please move to Norway. We will take good care of you. We basically all sectors are struggling by finding enough people, and especially after COVID, you know, it's a challenge. So what will then be important going forward? And I think, as you see, some of these problems are also problems you will struggle with, but you will also see that some of the solutions we try to implement to solve these things has not so much about decentralization to do, but we need to be better to prioritize. We need to basically take good care of the people that will work in the healthcare sector. We need to handle this coordination, this inter-sectoral coordination problem. We need to find more people that will work in the healthcare sector because, you know, the people in Norway, if you ask them what is the most important thing, if they ask to rank things, they will put healthcare on top. So healthcare is like the main political issue, even though, you know, most of the healthcare sector is unpoliticized in the way we have put up the structure. Well, we have to be more environmental friendly and sustainable, of course. We have to be innovative, find new ways to organize the services so we can solve the problem, and we have to improve the population health. So these are you know, the problem we are struggling with, and probably this intersectoral coordination is something which is maybe more specific for Norway, but we saw the same in the UK, for example. So what are then the solutions we are working on? Well, we need to do these like structural reforms. The problem is that there is very, very little political acceptance for doing these structural reforms. You know, so we have quality issues, you know, because we have challenging finding people that are willing to work in or will work in the healthcare sector. So we need to do, for example, me at this like regional hospital board, we need to find ways, you know, to centralize basically, because centralization is one way to make sure that we have enough people with good competence to work there. So, but it's very difficult to do, and you mentioned these like voting theories and this like political economy. Typically, it's the strong people with high education, high income that have a lot of influence. What we see in Norway is that in these rural, small municipalities, you know, people with no education, they just go in the street and say, "We don't move our hospital And the politicians listen to them. So it's like a very interesting thing, I think, from like a political economy point of view. Why do they get so big impact when these are, let me not say more like people that are not these like power people in the society. So that's a big challenge. So we in the hospital board, or in this like regional board I am responsible for, we have to make all these like structural changes so slowly that basically we try to get under the radar. If it blows up in the newspaper, then it will just, we have to stop. So we have to use the personnel we have better. So we are working on, getting more generalists into the hospital sector, especially. And that's a problem, because if you look at the young medical doctors, they want to be a specialist, in this area. They want to have like a career path, and we say, no, we want you to be a generalist. And of course, if I get sick, I don't want to see a generalist. I want to see a specialist. So this is a big challenge that we are handling. We also work on task sharing, try to put some of the doctor's tasks down to the nurse, from the nurse to the nurse assistant, because we have more nurse assistants than we have nurses and doctors. But again, it's difficult because these people also want to have like a career path in the healthcare sector. And then the labor unions are very strong in Norway. So the nurses' labor union is very strong. They have like a lot to decide when it comes to the rotation schedules within the hospital sector. So we have a problem in the sense that we cannot align the staffing to the demand at the different institutions. So this is a lot of challenging things to handle. And then we have these issues about how do we handle this intersectional coordination, and the that the government is putting forward is to have more integration. If you look at contract theory, since we are economists, and there are transaction costs in theory, there is a lot of transaction costs and issues, with hold-up relational investments that had to be handled. And I'm not sure if just putting everything into one big institution is going to solve a lot of these problems. So I think there is a lot of like nitty-grittiness that we have to dig into using what we know from, for example, contract theory, to really understand whether and how to use integration as one way to solve these problems. I mentioned that. So what about how do we get more, how are we able to become like an attractive workplace? Well, we try to get more full-time positions, especially nurses. We still have nurses that work part-time positions, so we hope to by giving them full-time positions. On the other hand, a lot of nurses are not willing to work full-time positions. So this is really like a type of both a supply side and a demand side issue. The problem is that when you have these like rotation schedules, if you put people on full-time positions, well, we have a lot of people that goes around also when the demand is relatively low. So it's like quite a costly solution. There is also, the current government in Norway is a Labour leftish government, and there is also like a big worry that healthcare personnel choose to work for private healthcare providers. We don't do, as I understand it has been done here, that you are like increasing the salaries for those who say they will only work in the public sector. What is being discussed is that if there should be like tighter regulations of these like private healthcare providers. So we don't want to use salary. It seems like the current government is not so keen to use salaries as a way to keep people in the public sector. Environmental friendly, well, not much is happening, but we have to align to the ESG regulatory framework, and you know, this regulatory framework in the EU perspective is being tightened, and there is always a discussion that, well, should this like new regulatory framework that the EU implement, and since we are a part of this European economic area, we also should implement them, but should we implement them in the healthcare sector or not? And typically after a couple of years we implement them, and I am chairing the audit committee in the Sacro regional health board, so then it end up in my table and I have to implement them. So, but it's a very, very slow process. Innovation, while we are thinking about, you know, digitalization and try to make investments in labor-saving technologies, and when we think about digitalization, it basically means standardization, and standardization means less decentralization. So I think this idea about that the digitalization is going to solve a lot of this problem we have means in practice less decentralization, because it has to go through standardization. So but this is also something which is not very much like openly discussed, the relationship about digitalization and how that will affect decentralization. But digitalization is like that's the big solution that we hope for. Yeah, and then we need to strengthen primary care. We are not there where you are in the NHS, where you have like made big reforms, but what the government has done at least is to increase the funding of the GPs, and it also we also work on thinking about whether or not these GP offices should be more multidisciplinary, but the GPs are not very, very keen on that. You know, the GPs, they would like to be the coordinator, and I think that I think that's a good idea. You know, they should be the one that are like coordinating, you know, all the types of cares, not the patient themselves or the relatives to the patient should be the coordinator. And the GPs argue that, well, if you make the GP offices more multidisciplinary, or if you put more, you say that pharmacists can do more whatsoever, then you have even more people that you need to coordinate. So that's their argument for why they should be the coordinator, and in some sense give us more money, and we will take better care of that task. So I think that's the role that they have. Yeah. So these were some of the problems that we have, and some of the solutions that that are being proposed now in a recent white paper, which is now being discussed in Parliament. Let me just end by so I didn't put up any papers and stuff, but this is a paper I wrote together with a couple of professors and colleagues from the University of Oslo, Tor Iversen and Eline Aas, where we basically go through the reforms that happened in the Norwegian healthcare sector from like 2000 up till like almost to 2020, and also, what should I say, academic evaluation of these reforms. So if you want to learn more about, you know, the specific of the reforms and evaluations that are being done, I suggest that you just look up that paper. So there you see the more, what should I say, the more like academic twist of the talk I gave today. So thank you very much.
Okay, so thank you very much to the four speakers. You kept your talk very much on time, so now we have some time in case you want to talk to each other or ask questions to each other, or in case the audience wants to ask questions or make comments. So just raise your hands. And if you can say who you are and who is your question directed to.
Okay. Okay, good morning. I'm Oriol Roca from Universitat Autònoma of Barcelona. I do have a specific question for Joan Costa. According to your results, you mentioned that decentralization reduces regional inequalities, right? And my question is, you mean health regional inequalities? And if you mean health inequalities, how you measure these health inequalities in terms of life expectancy, mortality, health quality, or whatever? Okay, this is the specific question. Thank you.
Is this working? Great. Yeah, so thanks so much for the question. I didn't go into any details, so I'm very sorry. So I'm sure that you ended up having more questions than answers. But, so we measure inequality. There's different ways to do that. We've done several studies out there. One that measures regional inequalities, right? So inequalities between regions. And the measure of outcome there is what we call a proxy for output, which would be expenditure per capita. Which is basically the measure of output that's more or less used across the literature. But then we've done as well other studies where we look at, for instance, with Joan Gil, we have a study where we look at inequalities within the regions as well, right? And there you find no effect. So decentralization doesn't affect the inequality within, and it reduces the inequality between, right? So altogether it reduces inequality, but most of the effect is due to the inequality between. And that has to do with policy innovation and diffusion, which is the argument that we were mentioning before. And I would argue, and I might use this time just to reply or comment on some of the previous points. I think that I would argue that the health system that is decentralized needs politics. Right? So perhaps one of the differences between Spain or Italy and Norway is that politics is very important in at least the south of Europe. Britain is actually experimenting. Manchester is now developing its own health system, and the Manchester Assembly is responsible for making their own decisions. And I think politics provides for an incentives for the health system to get choice, to deliver, to satisfy heterogeneity in preferences and needs. And then I know that Finland, which is a country that sort of compares to Norway, is going the other way than Norway, is actually decentralizing the health system even more. So it's interesting to see that perhaps Norway is a bit of an outlier there, that it's actually so wide that it's decentralized by default, and then perhaps a system that is so decentralized maybe needs more centralization. But other Scandinavian countries like Finland are just following the Spanish sort of or Italian pathway, and they seem to be decentralizing the health system even more. So it's kind of interesting. But so something interesting when you look at least Spain is that decentralization actually steers people towards using more the public healthcare system. So it's actually deterring individuals from relying on private providers that are not in the network, which is important, because that's kind of like at the core of the values of an NHS system, right? So you want the system to be public and free at the point of use, and decentralization is very, very compatible with that idea.
Okay, my name is Andreas Kiriakou. I'm from the University of Girona. I have several questions, reflections. I'll use your first names, if you don't mind. The first one is for Caroline. We have been working on decentralization in health systems also, using World Bank data, and we've seen that a lot of spending decentralization, expenditure decentralization, is at the local level in a lot of countries, also OECD countries, right, like Denmark, Sweden. I was wondering whether, because I was interested to see your report, you do have decentralization of authority, differentiating between regional and local governments. I was wondering whether the OECD also differentiates spending in health down to subnational governments, but beyond that, between regional and local governments. That's my first question. The second question is for Joan. We have learned a lot from your papers because we've worked on decentralization in general, but health decentralization lately. So this is something that we have taken out from your work. We have a recent paper in Publius where we find that decentralization of health spending down to local governments has a negative impact on health access and quality. And one thing that we find is that this effect is moderated by the size of the municipality. So we find that bigger municipalities, like more than 300,000 people, are able to perhaps harness economies of scale, and also we also find that something related with political structure affects this. I'm not going to go into it, it's too detailed. I was wondering whether you could say something about the size of the jurisdiction, right? Because it's a cost and benefit analysis, right? Between the benefits of decentralization, innovation, information advantages, etc., and the cost, economies of scale, and spillover. So maybe you have something on that. Then the third question is for Oddvar. It was very interesting to see the Norwegian example. We also work, I work with Uriol, by the way. We also work on governance issues. So we work on corruption in general and its impact on public policies. And now we're working on a paper which relates corruption across European regions to health, perceived health quality. And of course, we find a negative, more corruption, less health quality. So that the first, my question here is that governance is very important, right, in order to make things work. Beyond the fact that Norwegian municipalities have this, if I understood it correctly, the first level of care is at municipal level, right? There I have a question whether this is working, this is something that's functional. What are the health regions doing in the system, right? What type of coordination are they doing? Because there must be some, with such small municipalities, there might be a problem. Then the other question is, do you think that the Norwegian example can be translated to many other countries, right? So there's a lot of spending capacity, but other countries have less resources, and maybe they have some governance problems, which make it difficult to execute the desired policies. And sorry, I have a couple of questions for you because it's very interesting, Norwegian example. And the last question is these structural reforms, right? Because at least here in Spain, and I could also think about the United States. My question is whether in Norway structural reforms are possible, because in countries where there's a lot of political polarization, for example, where the parties are very divided on many issues, reforming the health system, or even more ambitious, reforming the degree of decentralization in the country is like a taboo area, right? It's very delicate, right? In the US also, it's something that's happening, right? So my question is whether this, do you think, for example, in the case of Norway, this is possible because there's like a consensus at the national level that these type of policies have to be reformed in the most rational way possible, or whether also in Norway we have issues with, polarization, etc. Thank you very much.
Not sure. Oh, there we go. Now it's working. Yeah, so thank you for your question. Yes, we have data for regional and state governments. So we define subnational governments as regional plus local government expenditure, and that's our categorization for subnational governments. I showed that breakdown for the decision-making power, but it's true I didn't show that breakdown for expenditure, but we can look it down further into regional and local, and then we define central as central government expenditure plus social security funds. So yeah, we do have that data, but it wasn't shown on the expenditure graph, just to keep it simple.
I know. So yeah, thanks again for the question. And I fully agree that we should think about decentralization in terms of functions, right? So the debate is not about decentralization versus centralization. It's about which function you want to allocate to which level of government. So it might, if you try to allocate a function that has huge spillovers at the local level, is going to be inefficient. That's what that's basic fiscal federalism theory. I'm not saying anything new here. But it's true as well that every health system is different. There's no one size fits all, right? And it might be that what works in Norway doesn't work elsewhere, or the other way around. So I think it's quite important just to consider the wider spectrum of, let's say, political constraints. So I fully agree with your point on governance, right? So governance is at the core of decentralization. And that's why, without politics, all this debate on decentralization, without understanding how the politics works and the dynamics behind let's say, the political game, it's almost impossible to understand what would be the final equilibrium, the final, basically, outcome of a decentralization process. So over to you.
Thank you. So the Norwegian system, these regional bodies that runs all the hospitals, they are not political. So the challenge to do, and as I said, the healthcare is the main thing that people care about. If you ask them to rank what are these topics they are most concerned about. So of course, a politician will never keep the fingers away from something which is important for the voters. So that's the thing, and I think the challenge to be able to do these structural reforms is that the structural reform will always create some losers and some winners, and the losers are going to complain. The politicians will then realize that, oh, there are some voters we can try to attract. So it's very, very difficult to do a reform, and then the politicians are going to say, we accept that there will be losers. So typically what is happening is that, well, me, as a board member of this regional board, I get the budget, and I have to allocate this budget, and I have to fulfill some tasks. And for example, we have issues with long waiting times, so we want to do something. And if this will then include, moving some services, say from one hospital to another hospital or whatsoever, people will complain. And then the politicians who gave me the budget said, well, this is the budget you get, and you have to do the best within this budget. They are going to say that, what are you doing? We are not going to support you. We deny you to do what you want to do. So that's the problem, So the politicians are blocking a lot of these reforms that are necessary to do according to be able to align, the tasks we should fulfill with the resources we have. So I think that's the problem, and I think that's the way it should be, in the sense that because health is a political issue. But this is why I say that, well, when you have to do these reforms, you have to do them so slowly that you don't create all these opposition that the politicians will play with. But what we see is that, well, when we have these issues with the problem of finding healthcare workers to work in these remote hospitals, there will become issues with quality. We have these birth clinics that some birth clinics, they have 12 births per year. And you demand there should be a full birth clinic, so you need to have 3 doctors specialized in their area. They should sit there and basically wait for this 1 birth per month. And you say, well, this is bad for quality, it is costly, but we are not allowed to do anything. And the few mothers or expected mothers in this area, they will be there. They will say, of course, we want to have these services close. So these, so how do you handle these things, and can you then transform, the Norwegian solutions to others? I'm not sure. But I think, I'm not. I guess you will have the same issues here also. People want to have services close to them, but when they get sick, they want to go to the university hospitals. They want to have the best service ever. So, and how you should handle this type of the need for prioritization, that politicians are going to accept that the prioritization means that not everything is going to be prioritized up. Something is by definition going to have less priority. That will create losers, which feeds back into this like political economy or the healthcare sector. I think this is a problem that we always will have, which means that the solutions are going to be like a pendulum. You know, sometimes we will go towards more centralization. It didn't work. Then we tried decentralization. It didn't work because we have these like issues with asymmetric information, with this political economy, all these transaction costs, and that's the way it is. So I think it's more that we will be switching between, in all countries, we will be switching between different solutions, and we will not be able to solve them. So in that sense, yeah, it's transferable. In the other sense, it's not going to solve a lot of problem by transfer it. It's just going to put emphasis on different aspects of the problem. I think that's one type of answer I can give. You are more like a political economy than I am, so you maybe want to reflect on this also. Yeah.
Okay, so if there is one last question, we can take it, but otherwise we'll be having coffee in the next room, and then we'll resume in about half an hour to talk about the Netherlands with Misja, Mikkers, about Italy with Gilberto, and then 2 papers talking about evidence on what happens in the Spanish context when we decentralized the healthcare system. Núria Mas from IEB is going to talk about a paper on what happens, what are the incentives for doctors, and then Lola from the University of Granada is also going to draw on some of the evidence that she's been studying for the Spanish case. So thank you very much, and we will see you in a few minutes. Thanks.
presentations, and then we'll continue with some questions and the discussion. So we'll start with the Netherlands, with Misja Mikkers, with Professor of Economics at the University of Twente. It's all yours.
Thank you very much. I should keep time, I guess. I'm very pleased to be invited and to hear all the interesting presentations until now. There's lots of things that I wanted to tell as well, so I can skip some things. Oddvar rightfully mentioned that the context of the healthcare system does matter a lot. And to compare, for example, Norway to the Netherlands has like 12% of the area in Norway, so it's much smaller, but more than 3 times as much as inhabitants. So we have like a very densely populated country. Or you could say that we are a thinly populated city, because we have like 50% more inhabitants than, for example, the greater Paris area or the greater London area. So we have a very densely populated country, and most people, like 99% or over, has access to a hospital within 30 minutes. And still we have the same discussions as Oddvar mentioned about closing services or hospitals. But the fact that we are so densely populated really explains the system that we chose, which is based on competition. And if you want to have like a system based on competition, then people should have choice. And if you could have choice, it is the Netherlands. And I will explore a little bit like on how this works and what it means in terms of equity and fairness. And explain a little bit how do we solve one particular problem, which is called adverse selection. Which is the good one? This one. I was also going to tell you a little bit about the hierarchy or centralization versus decentralization, but Joan took care of that. So let me just say here that we decentralized our system a bit in a different way than Joan mentioned. So, for example, the youth care in the Netherlands is delegated to the municipalities, and unlike that's a proof, unlike what Joan said, that decentralization really led to less equity. So there is huge differences between the municipalities in treatment, probability of treatment, and the intensity of treatment, and also waiting lists. Long-term care is kind of delegated to a regional purchaser, more like the clinical commissions like in England. But I want to focus a little bit more on the health insurance, which basically covers everything that is hospitals, GPs, mental health care, physiotherapy, and things like that. So we introduced a system based on competition, and in a moment I will tell you on how this works. But an important thing to remember is that competition requires a lot of prerequisites, and they are not met. So, for example, healthy consumers sometimes don't want to pay for unhealthy consumers. We call that in economics the problem of adverse selection, and I will tell a little bit on how we solve that in the Netherlands. There's also that insured consumers may consume too much. Therefore, we could introduce co-payments. They're particularly low in the Netherlands, as in Norway, probably. And Oddvar also mentioned already the agency problems. And then there are problems if you have competition with market power that we have, and coordination problems in contracting, and I will go a little bit into that because that also combines well with what Joan and Oddvar said about the coordination between different services. So how does this competition work in the Netherlands? Citizens choose an insurer, a health insurer. And on their behalf, the health insurer will contract healthcare from providers, which could be GPs, which could be hospitals. So selective contracting is possible. So what you could say actually is that a health insurance is basically a financial instrument in the sense that what you buy is basically an option on a bundle of access rights. Right? So if you get ill, you can go to a hospital that is contracted. Actually, you can also go outside the contracted network, but then you have to pay extra. It's just a small amount, but you have to pay extra. In theory, if the market would work well, then every insurer would contract every provider, because that's beneficial for everyone in a game theoretic model. In the Netherlands, there are some insurances that offer selective contracting practices because they say it's better negotiation. I think there are different reasons for that. So the problem, however, is that if people choose health insurers, they are not equal, right? So they have different expected costs. So here I just plotted gender and age. And you see, like, if people get older, they just, what we all know, they are more expensive. In the Netherlands, women typically are more, they're cheaper in terms of healthcare cost than males. They are more expensive in total because they live typically longer. However, there is one period where females are more expensive, and that's the pregnancy. And if I will not forget, I will tell you a little bit about the consequences of that in terms of contracting good healthcare. And it shows you how important contracting actually is. So the problem is that for insurers, some people are really profitable because they're young and healthy, and other people are sick. So old and sick and expensive. So, first of all, these young people might not want to insure themselves, right? So we try to solve that by saying that every citizen in the Netherlands is obliged to buy this health insurance. So, in a sense, that makes that the healthy people will have to buy an insurance while they have no net benefit of that. So they're basically sponsoring, by buying this insurance, also people with higher expected costs. But it also means that since the government, it has like two implications. Since the government forces people to buy an insurance, it's considered to be a tax. So I was a little bit surprised in the presentation of Caroline that we had so low state expenses because we consider the payments to our private insurers to be a tax. Because the government forces you to buy this product from a private insurer. But if the government will force you to buy something, it should also tell you what it is that you should buy. And therefore the government determines the benefits package. So the government determines what the insurance really is. So it's the Minister of Health that says what's in your insurance and what is not. Because otherwise this obligation would not make sense, right? So if the government would force you to buy something and health insurer could sell you something by saying, okay, if you get ill, you get like €1 and see what you can do with that, that's basically the same as having no insurance at all. So if you want to oblige people to buy an insurance, you should also define the uniform benefits package. It also means that insurers have lots of obligations. So the first one is they have mandatory acceptance. So if people want to go from one insurer to another, they want to switch, which is possible once a year, the insurer has to accept you, regardless of pre-existing medical conditions. So if you had like breast cancer or you're HIV patient, the insurer still has to accept you. Furthermore, he cannot discriminate in prices. So for an insurance, all premiums are equal. So regardless of your expected cost, you will pay the same. And lastly, and that makes also for Caroline probably, this makes budgets uncontrollable for the government, waiting lists are not acceptable. And also that has to do with the fact that we have an insurance that you have to buy, because again, if you would sell an insurance and said that you have to wait 100 years before you get like a treatment, it still is the same as no insurance at all. So waiting lists in principle are not acceptable, which also means that if there's determined that you need healthcare, it should be paid for. And budgetary reasons cannot be a reason not to get care. So we cannot ration by waiting lists as in Norway, because that's explicitly forbidden in the law. And that makes it also very hard to control healthcare cost. So given the fact that people have really different underlying healthcare cost and are charged the same premium, it makes that some patients are really, in principle, loss-making and other ones are really profitable for insurers. So you would expect a lot of cream skimming. That's not allowed. But to kind of mitigate this effect, we have a fairly elaborate risk adjustment system. So the funding of our system is that like half of the estimated healthcare cost is paid directly in the form of a nominal premium to the insurer. And that's the equal premium for everyone. That's the premium that you pay to your private provider. The other half is collected by the state. And it's collected based on an income basis, so it's income dependent, so rich people pay more. So on the enrollee 1 on the left side, that's a rich, healthy enrollee, to make things a bit simple, and on the enrollee 2 is a sick and poor enrollee. And as you see, they pay the same nominal premium. But the income-dependent premiums really differ. So poor people pay less than rich people, and poor people also get the tax subsidy back, like specifically for healthcare. And this money is put in a risk adjustment fund, and it's paid out to insurers based on your expected cost. So in all countries, basically you have to deal with two things, and we kind of neatly separated that in the Netherlands. It's income solidarity. You want to have the rich people pay for the poor, otherwise they cannot afford healthcare. And you want to have like an income transfer from the healthy to the sick. So that's the two things that you should arrange in any system. And there is like one caveat that I realized this morning, is that you also have to think with whom you feel this solidarity. So for example, we feel solidarity with everyone within the Netherlands, but we don't feel any solidarity with respect to people in other countries. So we've seen like the differences in healthcare spending in the sheets of Caroline, and also we also know that will lead to differences in, for example, life expectancy. We don't feel any solidarity within Europe. That's different than in the United States, right? Because they there have Medicare, regardless where you live in the US, they have the same right to healthcare if you're 65 or older. And that basically means that a country like, I would call it a country, like Massachusetts really pays lots of income transfers to a state of Alabama, for example. And we're not there in Europe, so for Joan, if you want to go more to a European level, there is lots of things to be done in terms of solidarity and income transfers, and it means a lot, actually. So I've once calculated the income transfers from the Netherlands. If we would have like a European system that is based more or less on what we pay, then it means that we have to pay 2,000 euros extra per year just to other countries. So this is like, it also means that we have to assemble lots of data of everyone, because we estimate the cost per person. So actually, if I am enrolled with one insurer, the insurer gets money for me, depending on my age, my gender, my former diseases, my source of income, my zip code, lots and lots of things, like a few hundred variables are taken into account. It's also a privacy nightmare, right? Because we assemble all this data of all these people, and they're also available for research. That's a good thing. The bad thing is that, like, there's lots of discussions about privacy issues in the Netherlands. Now, how would this work out? Like, so for elderly people, insurers receive much more money than for poor people, from young people, which basically means that the idea is that everyone should be equal in terms of expected cost for insurers. Of course, people are not, because one of the very kind of notable exceptions, if I go back, are women in the pregnant ages. And to give you a little bit insight how this works, so it basically means that women that are in the pregnancy age are loss-making for insurers. So insurers really would like to have women that do not want to get pregnant and not have women that don't want, that want to be pregnant. And there is one, and for example, that's the reason that students were really profitable for insurers. They were profitable for two reasons. Students live typically in bad neighborhoods given their health status, and female students don't tend to get pregnant. So you could select a little bit, but actually it's worse because women that tend to get pregnant are also persons that switch from before pregnancy. So women that want to be pregnant, they will go through their insurances and then switch typically. So it's a large group that switch. So now, if you as an insurer would contract very good healthcare, then you would attract a lot of loss-making women. So one insurer did that in 2012, and they were forced by the central bank, because they are financial institutions, to stop this insurance immediately, because there was a risk of going bankrupt. So this year it was repaired, so now pregnancy is also in the risk adjustment system, but you can see how far-fetched this kind of risk adjustment is. How does it function? So the interesting thing is that when you look at basically every indicator that you could find, the Netherlands performs kind of average for the cost it takes. So in terms of life expectancy, cost, survival rates with cancer, trends are basically equal in most countries. Since we have a system based on competition, I would like to say that the system is kind of fairly accessible and equitable. So here you see self-reported unmet needs for healthcare due to financial reasons. Most people, we are typically people in the Netherlands say that their healthcare needs are met. And the differences between the poor and rich people are kind of more or less equal. I have to hurry up, I understood from Alberto. So the Dutch healthcare market is characterized by a high degree of decentralization, because all the allocation decisions on who does what is allocated to insurers. But it's done with a large amount of central regulation, actually. As Joan mentioned, that what we see in the Netherlands, we see a lot of experimenting going on with different contract forms. Unfortunately, it's not much researched. There is one problem, is that the different contracting schemes per insurer lead to coordination problems in two ways. So there are problems in terms of incentives. So suppose that one insurer would experiment with a two-part tariff, another would do like a fee-for-service. You really undermine the incentives of the provider, unless, and that's what we don't want, unless you allow hospitals to treat patients of different insurers in a different way. And that's not accepted. It would be practical, not be feasible, I would say, but it's also not accepted from a medical point of view. But it also leads to problems in terms of allocation of production rights and scale and scope issues. For example, if you want to centralize certain operations, insurers should form a cartel, which they are prohibited of, to arrange that. So it leads also to all kinds of problems. So I would say, like, we have a complex system with many actors. Outcomes are more or less comparable to any other system, I would say. And we have basically more or less the same challenges as, for example, was mentioned in the UK by Rita, and also in Norway and in Spain. So I guess the challenges with the aging population, the interaction for multimorbidity, the interaction with the social domain, these are challenges that we also have, and there's lots of experimentation going on in the contracting. That's the nice thing, but we don't have a final solution yet as well. Am I still on time, Gilberto?
Yes.
Okay. No, then yeah.
Okay, thank you. Thank you, Misja. So now we'll move from the Netherlands to Italy with Professor Gilberto Turati from the Università Cattolica del Sacro.
Well, thank you so much, and thanks to Judit and all the other members of this Institute for the kind invitation. I was really happy when I received the invitation because this is something I did research on a lot, so it's really a pleasure to present some of my, of what I understood so far, at least on the Italian NHS. I will spend most of my time, I have far too many slides with respect to the time I've been allocated. I would spend most of my time making the history of the Italian NHS and to provide background information, because I think this is important to fix ideas. Then I'll try to go to some lessons learned, and I want to make a point here. I want to make the point that academic literature provides some results which completely differ from political narrative, which is something that then impact on how people then decide to vote. And then I'll try to wrap up by providing some takeaway messages. So let me start from here. This is the law 8378, so long time ago. Why I suggest this law? Because it's the one that created the Italian NHS. What was before? There was a system of mutual health insurance funds that was reflecting the corporative nature of the Italian welfare state. They were in financial trouble, so the Italian government at that time decided to create this national health system. And the idea was to create a universal healthcare system, which was a sort of a novelty for the Italian corporative welfare state. So it was the unique place where there was a universal approach. If you take the pension system, also at that time, it was reflecting this corporative nature. So it was a novelty from this point of view, and basically reflects something that is enshrined in the Constitution, because Article 32 states that there is a right to health for all Italian citizens. Now, the goals of the reform was, of course, to change the landscape, so extend the coverage to a larger set of services, and also improve equity in health. This story about equity was strongly pushed at that time when pushing toward this universal healthcare system. Now, in terms of government, the NHS was created from the beginning as a multi-layer system. So if you speak about the central government at that time was in charge to defining the size of the National Health Fund. Then, of course, this fund was going to be apportioned to regional governments according to some formula. Basically, the formula was a per capita formula, then corrected for the age structure of the population, according to needs, basically. And then, of course, the central government was in charge of financing the system with taxes collected at the national level. This will be an important point later on. What about regional governments and local health units? They were in charge of organizing administratively and providing the services at the local level. Municipal governments were also in charge to organizing these local health units, and basically there was this political power that was intersecting the appointment of people that were governing the local health units. And there were these new bodies, local health units, that also owned public hospitals. So they were both playing the role of insurer and the role of providing the services. Now, of course, as we know from what Joan also said, in multi-layer system, we have shared responsibilities. And shared responsibilities brings about accountability problems. We can divide, at least in my view, the history of the Italian NHS in basically 3 periods. The first one is the 80s, where there was a large financial irresponsibility, and there was just administrative decentralization. This comes back to what Joan was saying. I'll try to be clear about what type of decentralization we are talking about in each of these periods, and I'll try then to explain why it is like that. If we go through the 90s and the mid-2000s, then there was this attempt to make reform to improve the spending efficiency using appropriate incentives, and this would be the age of incentives. And in that case, we use political plus fiscal decentralization to push toward the right incentives in order to provide a more efficient healthcare spending. Then, from the mid-2000s, we try to use another setup, which is this administrative subordination, because something happened at that time, and I'll try to explain what has happened. But in that case, we should speak, at least in my view again, only of political decentralization. So we got back from fiscal decentralization towards something that was different. And this is something that also in the academic literature sometimes it's not clear if you look at papers on Italy. Let me start with the 80s and the age of irresponsibility, as I said. These are the main facts for the 80s. There were large deficits in all the Italian regions. These deficits were followed by discretionary bailouts by the central government, and there was this soft budget constraint problem that was huge. The regional government were expecting bailouts from the central government, and this made the deficit problem even worse, of course. This is a graph I will speak about also in later periods. It's the aggregate deficit at the regional level, starting from 1987 to 2018. And if you see the first red box there, it's from 87 to 90, the aggregate deficit peaked 7 billion euro in 1990. If you think about the funding, it's more than 10% of the funding at that time. So it was a huge deficit. Now, why this deficit? Why the central government was unable to commit to a predetermined level of transfers? The regions had no incentive whatsoever to spend efficiently. Basically, they were paid on a cost-plus basis. Hospitals were paid for all they spent, and this was clearly a problem of financial irresponsibility. The central government were short-lived. If you go back at that time, it was less than 1 year. And third, we had a huge problem of vertical fiscal imbalance. The vertical fiscal imbalance was 100%. So it was all financed with transfer from the central government, basically, all the regions. And of course, according to fiscal federalism theory, it is the second generation of these theories, this creates a problem in terms of financial irresponsibility. Now, let's move to the age of incentives, the 90s and the mid-2000s. These are the main facts. Of course, coming from a decade of large deficit and large bailouts, we tried to fix things. How? Making reforms. Now, why reforming at that time? For 2 main reasons. One reason is because of the severe financial crisis back in 1992, and the second one, brand new fiscal rules at the EU level in order to join the Eurozone. I stress this point. At that time, the Maastricht Treaty was thinking about rules to join the Eurozone. It's different to remain in the Eurozone. We can talk about this later on. Which kind of reforms? If we speak about healthcare, we introduced, for instance, quasi-markets and political decentralization in 1992-1993. We introduced new regional taxes in 1997. So at unchanged constitutional rules, we introduced a new system that was speaking about political decentralization, but also fiscal decentralization. Plus, of course, new electoral rules in order to strengthen the government at each level, central government, regional government, and also municipalities, but we also reformed pensions. This is the financial effect of introducing new taxes in 1997 on the vertical fiscal imbalance. And as you see, at the national level, it was about a shock of about 40% in terms of reduction of transfer from the center, which is quite large effect that you can see. But of course, this is different across different types of regional government. So let me take the two extremes. One is the poor region in the south, Calabria. The shock is just 20% at the beginning, and then it goes down to 10%. So it means that you have a deficit over there. 90% of your money comes still from the center, and just 10% comes from your citizen. If you think about Lombardy, it's just the opposite. So it's 60% that is coming from your citizen, and 40% that comes from, say, the central government. And this is unavoidable in a system where you have large income differentials. It's just the same everywhere, basically. This is the effect on the deficit. First, the deficit goes up, and then it goes down in 95, basically entirely wipe out. Why 95 and 96? Well, because we were going to enter into the Eurozone, so we needed to take the budget as much control as possible, basically. Then it goes up again, but then we introduced new regional taxes. So the second decline that you see over there is likely related to the fiscal federalism story. New incentives that are coming in because you are paying taxes. And in fact, when the deficit peaked up again later on, this was much more concentrated in poorer regions, or in regions like Lazio that are too big to fail, according to another theory related to this stuff. Let me move to the third period, the age of administrative subordination. These are the main facts. After having done this fiscal decentralization without changing the constitution, we did decide to change the constitution in 2001. So the change in the constitution comes later on. Then, after changing the constitution, of course, it started a bitter confrontation between the central government and the regional government in order to define what is the real meaning about political autonomy and fiscal autonomy, and where this bitter confrontation is brought about toward the Constitutional Court. So there are many cases at the Constitutional Court that discuss exactly this issue. And I will speak about one of these that is important. Because this case here brought to the collapse of the seminal fiscal decentralization story and maintained just political decentralization, and the inability to find a political compromise is something that we are still experiencing right now. The constitutional reform tried to balance efficiency and equity. This is something that has already come up in our discussion today. How do they do so? They say, okay, central government is in charge of defining essentials level of care that should be provided everywhere in the country. And it is also in charge of funding every region to provide exactly this essentials level of care, plus defining framework legislation. The region can legislate with the autonomy that is opened up by the framework legislation. So the more the framework legislation is detailed, the less autonomy you have, of course. And then there is also some autonomy in rising revenues. That is, at that period there, it was modifying tax rates of regional taxes. They were called like that. Now, we know that constitutions are in complete contract. So after the constitutional reform, you start thinking, what does it really mean for us? So you take a region, you write down a legislation, a new legislation that says something about, healthcare, and maybe the advocate of the state comes up and say, you can't say this. And one of the most important, ruling of the Constitutional Court is this one, is the Regional Law 2202 of Piedmont that exempted the agency for the 2006 Winter Olympic Games from the main regional tax. So the question that was brought to the Constitutional Court is, can the Piedmont region do something like this? At that time it was this regional tax on productive activities, and the question is this really a tax, a known tax according to Article 119 of the Constitution? And the answer was no. And the argument is typical of law scholars. Basically, the idea is that that tax was introduced by the national parliament, so it's a national law. It cannot be considered a regional law because in the case of a regional law, it must be a tax that is introduced in the, in the tax legislation by the regional parliament, which was not the case. So get back at that point and think what was the effect of this, on regional governments. We were supposed to be autonomous, but it's not the case, basically, because of this. That's why the incentive system based on tax decentralization collapsed. And the EU rules at that time, because we already joined the Eurozone, were unable at this point to curb bailout expectation, at least for those regions that were the poorest region in the country. And in fact, the aggregate deficit peaked again at 6 billion euro, but this time the deficit, as I said, is mostly concentrated in some region. Which region? Mostly the southern one. Now, in the absence of a political compromise, the story goes on like this. We introduced a new instrument, instead of thinking about incentives, which speaks about recovery plans. We need, in the case of financial troubles, that is a region running a deficit greater than 5% of the overall level of funding, to go through this recovery plan. These are multi-annual plans. It's something similar to those plans that are thinking at the EU level for countries, basically. So it aimed at restoring the balanced budget, plus improving the delivery of essentials level of care, which basically means a sort of a spending review kind of mechanism. And it implies imposing an increase of regional taxes. So the central bank comes to you and asks you to increase the tax in order for your citizens to pay for this. You block the personnel turnover and you ban non-compulsory expenditure. And this is a map of the regions that underwent this kind of recovery plans. And as you can see, besides Piemonte and Liguria, that are two regions in the north, all the other regions are all the regions in the south. So you have Abruzzo, Molise, Campania, Puglia, Calabria, Sicilia, and Sardinia. All the regions in the south except Basilicata. This is the only region that was out of the square at that time. What was the effect of this? The effect of this was to, again, almost entirely eliminate the deficit in all these regions. And there is now a discussion about what is the effect on health and the access to health care. I will speak about this later on, but in terms of descriptive evidence, all these arrow points downward to the right, it means you reduce the deficit and you increase a little bit the score in terms of essentials level of care that is computed by the Ministry of Health. Now, what are the open issues in my view? In terms of decentralization, basically the financial crisis in 2011 imposed a severe control of spending growth for every country of subnational governments, basically. And this is likely one of the reasons why the attempt to reintroduce, say, some sort of fiscal decentralization remained basically on paper. The other main reason is that the country is politically divided between those in favor and those against decentralization of autonomy. We tried to impose a new constitutional reform in 2016, going to less regional government autonomy, but this was blocked by a national referendum. So as a response, 3 regional governments, basically Lombardy, Veneto, and Emilia-Romagna, invoked Article 116 of the Constitution to ask for asymmetric federalism and to ask for more autonomy. There was an agreement with the Gentiloni government back in 2018, then it follows the Conte first government, and then the COVID came. So what is the situation right now? There is a new draft bill proposed by Mr. Calderoli that is being discussed actually those days, those months by the parliament. But what is important to know is that this bill does not forecast, say, any discussion about fiscal decentralization. So the effect of this reform, if it will be approved, will be only in terms of political decentralization. And this is particularly strange for what we said, because, for instance, there are new functions that are coming in for this, say, regional government, like education, which implies a large spending. So it would be like in Spain. I know that here also education is decentralized. And in the case of Italy, it could be something like that. But without having this fiscal decentralization story and without having any new tax. Now, lessons learned, very briefly. We think that bailout expectations matter, are diversified across regional government, and affect inefficient spending. Fiscal decentralization contributed to curbing bailout expectation and produced the effect that we expected, plus some other. For instance, we found evidence that reduced within regional healthcare inequalities, reduced infant mortality rates, reduced the share of inappropriate C-section. So it means we found an improvement in some of healthcare outputs. Recovery plans basically eliminated deficit, and there is a discussion, a small literature that is coming in, discussing what are the effects in terms of health. Some people find negative effects in terms of health, but these negative effects are small and are found when you do not account for the endogeneity of a recovery plan. Now, here it comes one of the points I was trying to make at the beginning. Despite this result of the academic literature, the political narrative suggests mostly negative outcomes when speaking about the decentralization. For instance, decentralization is said to have increased corruption cases, is said to have increased deficit in some regions. Certainly, here you see a clear north-south divide in terms of what people think, and north-south divide matter because people even in academics push against decentralization and against autonomy. My argument here is that we do observe these differences in terms of the quality of services, even for functions that are highly centralized. So if you take education in Italy, that right now is centralized at the national level, you still observe a gradient between the north and the south, which of course is not related to decentralization. And people should explain why we observe this gradient here without having this decentralized. I think, and I finish, that there are unavoidable conflicts in all multi-layer systems between levels of government and between strong and weak regions. This is observed everywhere in the world. We can try to obtain cost efficiency in different ways, according to the Italian story. One is about using incentives provided by fiscal decentralization. The other one is about administrative subordination. But we always need to show, I think, and this is again an important point, how efficiency does not harm equity across different territories. The fear of potential inequities, in my view, largely explains the difficulties in implementing fiscal decentralization in the Italian case. And last point, the COVID provided large flows of funds to regions, likely increased bailout expectation and inefficiency, and some of these are surfacing out. But it also showed, and this takes a point already made by Joan, the decentralization story in healthcare should be reframed. So we need to think that there is an additional layer of governance, which is the EU. And we need to think about what functions that now are at the central government level should be moved to the EU level. And I'll finish here. Thank you.
Thank you, Gilberto. So now we'll stay in the Southern Europe. We'll continue with Dolores Jimenez from the University of Granada, who will give us an overview of Spain.
Thank you very much. First of all, thank you for the invitation. It's a pleasure to be here in such a beautiful town and such a beautiful place. So I'm going to give an overview. The slides, where are my slides? Here, yes. Yeah, I'm going to give an overview of decentralization in the case of Spain. And I'm going to start by talking about trends. So as in previous presentations has been shown, decentralization is a very popular public sector reform. And in particular, health is one of the pillars and one of the areas that has been mostly devolved. In Spain, it's the largest spending area of subnational government. So it's one of the biggest concerns for regions. There is a trend towards asymmetric implementation of healthcare. In Spain, we have two federal regions that have full fiscal powers in the north, Basque Country and Navarre. And also, we have had a gradual implementation of political decentralization in the other regions. There's also other examples of asymmetries in decentralization in other countries, such as Italy or even Sweden. And this gives rise to a lot of opportunities to explore using natural experiments, such as Scott Cunningham in the United States, that he says that he loves federalism for the natural experiments. Yes. I'm going to talk a little bit about the story of decentralization in healthcare in Spain. And one of the first regions that devolved healthcare powers was Catalonia in 1981, followed by Andalusia in 1984, then Basque Country, Valencia, Navarra, Galicia, Canary Islands, and finally in 2001, all the rest of the regions in Spain were devolved in healthcare matters. So it took over, the decentralization period was implemented over a 20-year period. Therefore, it gives rise to a lot of, there is scope for experimenting using this kind of setting, for doing natural experiments. The funding, now important. Up to 2001, there was finalist funding for healthcare. From 2001, things changed, and there is more fiscal autonomy, but healthcare is included within the general regional funding in regions. There is also some fiscal autonomy because around 25% of total resources of regions are locally raised. And then, however, there are some equality grants that have maintained the status quo across regions. Here I show differences in the income tax, the top marginal income tax across Spain, and we can see that there are differences in the income tax. The regions can raise 50%, they have chance to vary, and they can raise 50% of the income tax. And there are differences, for instance, Madrid, which is one of the largest, the richest regions, has one of the lowest top marginal income tax rate, and other parts of Spain, which are a little bit poorer, have a higher top marginal income tax. Also, there are differences in healthcare spending. I'm not showing graphs, but there are differences which are unrelated to the level of income. For instance, Asturias in the north is not such a rich region, but it spends the largest amount of healthcare. While, for instance, Madrid, being one of the richest regions in Spain, spends the lowest in healthcare. So there are quite a lot of differences in health. What is the rationale of decentralization? One of the rationales is promoting democracy. This happens mostly in developing countries by promoting local public sector accountability. In many regions, however, decentralization has taken place as a way to alleviate tensions between regions that are very different, historically, culturally, and so on. However, despite of the reasons, the literature suggests that there is a clear link between decentralization and some relevant economic outcomes such as efficiency, equity, and economic growth. So here we can see a little bit of a framework where decentralization, by tailoring better the needs of the population, allowing more participation, democratization, accountability, more transparency and efficiency, is allowed to provide better services. Then, if there are better services, people will be more likely to pay, moral tax will be higher in theory, there will be more willingness to pay, and therefore less cost to the government. This is in theory. So decentralization allows tailoring policies to local needs, matching the needs of the population, but also by promoting competition in different ways, as Joan discussed earlier, promotes innovation resulting in new services or initiatives. And it also brings about flexibility and diversity in local services, which promotes also learning by doing from one region to the other. And also Joan discussed some examples. I will bring some examples, but he gave plenty of examples earlier that I will discuss a little bit later. So when I talk about decentralization, I like to show this graph. this recent evidence on why decentralization could be highly beneficial from the innovative point of view. In the middle, at the beginning of the pandemic, when no one knew how to stop the spread of the virus, in Germany there was one province that went ahead the rest of the provinces and was the first province to introduce a compulsory face mask. So no one knew whether this would be beneficial or not to stop the cases of COVID, but because in Germany is a federal state and there's healthcare is decentralized, highly decentralized, so we know after that compulsory face mask was very, very useful to contain the spread of the virus. In Spain, what is the rationale in Spain? Now moving a little bit to our country. So we can see that there are important differences in healthcare coverage across regions. There are differences in vaccination across regions, also in cancer screening. For instance, the age varies across regions. But there is also evidence that decentralization has been tailored to the local needs of the population. After political decentralization, some regions decided to focus, for instance, on increasing the number of long-term care beds, for instance, Catalonia, while others, Andalusia, decided to provide more local primary care service to focus on prevention. There is a lot of evidence using experimental techniques, using the gradual implementation of decentralization in Spain that brings evidence of the benefits of decentralization in terms of health outcomes and also improved satisfaction, health services perceptions, and higher preference for public health care. So, for instance, in a study that I conducted with my colleague Pilar García Gómez, we found out that after decentralization, there were 2 regions that reduced substantially the infant mortality rates, which were those that were fiscally autonomous, Basque Country and Navarra. However, it didn't harm any other regions. So basically, decentralization was very beneficial for all regions, but it wasn't harmful for the rest. We can say that it increased disparities, but not at the expense of the poorer regions. It improved the health outcomes of the richer regions. Then I'm showing here some of the results of a recent paper that also Joan discussed earlier, in which he also exploit the gradual implementation of decentralization, and they find that decentralization has been beneficial in terms of citizens' preference for public health care and in terms of individuals using public health care instead of private resources. Now, one of the rationale also for implementing decentralization is that it allows more innovation and flexibility in local policy making. And in a recent study with my co-authors Silvana Roboni and Ángel Fernández, we found out that a recent policy implemented in the region of Madrid that collapsed all the health areas into one and introduced freedom of choice of provider for GP and specialized care. And this is the only region in Madrid in which this is possible, so citizens can choose from anywhere within the region. Waiting times were substantially reduced. So it was very useful, this policy, to reduce waiting times. The starting point was very high in this region. Also, I'm also quoting here work by people who are in this hall, like Judit and Guillem. So we can say that one of the rationales is that regions have more flexibility, and sometimes this could be useful to bypass national legislation that could be harmful, not only for the target population, like in this case, they studied the 2012 restrictions to undocumented immigrants that up to that date, up to 2012, were able to access healthcare services only by registering in the census, so it was quite easy. But from 2012, there was a ban, like a restriction, which meant that undocumented immigrants were not allowed to use healthcare in the same terms as before. So in this study, these authors show that this was very harmful for the avoidable mortality rate of the undocumented immigrants. But also there are efficiency arguments here. If you don't allow undocumented immigrants to use GP services, they will end up sometimes either dying or using emergency care, which is more expensive. Another example here, in a news, is that the rationale in Spain, I think, innovation, very clear. Decentralization has allowed flexibility, learning by doing, and here, although I can translate quickly, you can see the government is looking at Navarra, this foral region in the north, to choose what is the drug to be used to stop smoking, cease smoking. So basically, this saves cost to the government in general. By using like a pilot study, they can save cost. But there are also other examples of learning by doing that Joan discussed earlier, such as I think the second opinion that Andalusia I saw that was following most of the times, but was looking at the best initiatives that were implemented in its region. Challenges. Now, the downsides of decentralization. Not everything is good. There are also challenges associated. The main one is inequality. It could be a challenge. Mostly decentralization, if regional governments have to fund the services with their own money. Also, there are efficiency issues, duplications, and diseconomies of scale. I don't know if some of the people here who are not familiar with Spain, but there are very rich areas like Catalonia or Andalusia or Castilla-La Mancha, but also very small regions. Madrid is small, Asturias, Navarra. So there are some discussions about these economies of scale regarding this and some other issues that I will talk a bit later. An issue that decentralization can bring about and that can be challenging is privatization. It's not that privatization is an outcome of decentralization, but decentralization has happened mostly in NHS-type systems that were originally publicly funded. So decentralization allows for more privatization, and this is not a bad outcome per se, but it could be challenging, as I will explain a bit later on. And finally, lack of coordination. So you can see here, this is the Consejo Interterritorial, so the place where if there is some important decision in Spain to take place, there are 17 people, a big room, a larger table than this one, so they have to agree on, and this can be, there are a lot of transaction costs to take a decision here. Now, moving back to Spain, what are the challenges of decentralization? Here I show something that we studied and that is linked to my previous example. So basically, there is a lack of coordination that could be either across regions or resulting from a given policy. So 2012, austerity measures, some regions decided to follow the national legislation, others decided to opt out and bypass the law. Therefore, we evaluate and we find out that actually the probability of a GP visit was highly reduced for undocumented immigrants all over Spain, even in those regions that actually were still providing services to undocumented immigrants in the same terms as before. Why? Because there was so much confusion that not even the target population knew whether they had the right to use or not the services. The doctors were probably unaware. So the stakeholders, so there are chilling out or deterring effects from this confusing situation. Another challenge could be the expansion of private resources. This, in my previous example of freedom of choice in Madrid, we found out that freedom of choice reduced considerably waiting times, but also it could, we found out in the same paper that hospitals that attracted the most patients were also those that had that were privately managed and that could keep their own surplus as opposed to public hospitals. Now, we don't have data to discuss this. This is what I'm saying, that privatization could be a little bit tricky because we don't know exactly what are the outcomes of this reform. But what at least I looked in the news is that people who were choosing a different hospital were going to the dermatologist, gynecologist. So basically, they seem to be less severe patients. So there seems to be a little bit of perhaps some evidence of cream skimming in the system. And finally, I will talk about another challenge related to economies of scale. So an important thing or an important benefit of centralization is the economies of scale. So it's more efficient. For instance, when we are talking about medicines, one very good thing about the third layer that Gilberto was talking earlier, when we talk about decentralization, is that the EU decided to buy all the vaccines. So there was centralized purchasing of the COVID-19 vaccine for Europe, the AstraZeneca vaccination. But in Spain, each region has to negotiate to buy the drugs. Very recently, the central government has started to try and combine, to try and negotiate with those regions that want to be in the package. But basically, there are these economies of scale. So the central government only negotiates with the pharmaceuticals for those drugs that are included in the common package. That could mean a loss of economies of scale. And here I show the vaccinations that are included in the common package. Other services, well, the regions have to negotiate on their own, and this means higher price probably. So, to sum up, we can say from the evidence that we have that decentralization has been beneficial in terms of health outcomes, health system perception, responsiveness, and has also favored innovation and flexibility. Importantly, it has not been, at least from the evidence that we have, at the expense of the poorest regions. However, there are key challenges related to efficiency, these economies of scale, and sometimes lack of coordination. This is not only restricted to Spain, but there are countries which are highly decentralized that at times of COVID couldn't even compare the number of cases, for instance, Germany. And we have this problem as well. Sometimes indicators are very different, so we as economists have some restrictions to be able to evaluate and compare within the system. But there is hope that more and more research is being conducted, and also that regions are starting to, and could, and should, cooperate and collaborate more across them. That's it. Thank you very much.
Thank you, Dolores. So now we continue with Núria Mas from IEB Business School.
Thank you. So thank you to all the organizers for the opportunity to present here, and a special thanks to Dolores because she has presented how the Spanish system works. So that makes my part easier because I'm not going to tell you how it works. I'm going to tell you something different soon. In a second. So basically, what we are going to be here. So what we are going to be talking about here is we take advantage of precisely this decentralization of different regions in Spain adopting different policies, paying doctors differently, to see what happens when we try to encourage doctors to work more in the public sector by paying a complement to those who work exclusively in the public sector and not in the private sector. And as you see, the subtitle is the unintended effects of that. So you will see what we have. So just to start with some facts, most of the developed countries, as you know, have predominantly publicly funded system for healthcare that can be organized in different ways, with the main exception of the US. These countries also have a relatively large private sector, and in most of them, doctors practice what we call dual practice. So doctors who work in the public sector also have their private practice or spend some hours in the private sector. So for example, this dual practice in Ireland is 90% of the doctors who work in the public sector also work in the private. In the UK, 61, Norway, 25 of the men and 16% of the female physicians. And in Spain, in our data, we have 14% of doctors doing both. And this is quite controversial. So there are arguments in favor of doctors spending, public sector doctors also working in the private sector. Some of these arguments have to do with the fact that some of these doctors use or go to the public sector to build a reputation, and this also allows public sector that usually pays a little bit less to attract very good doctors. Another thing that might happen is that because we have this combination of doctors, that might contribute to decrease, that's an indirect effect, the decrease the burden of the public sector, because, you have, like in Spain, for example, national insurance for healthcare, but obviously some people also can buy their private insurance, and then you decide where you go. You have full right to go to the public sector, but if you go to the private, you decrease the burden. But of course, nothing is so easy. There are also some cons. Some have to do also with, some people argue that, for example, if these physicians work both places, you might just drop your pen, run to the private sector and put more effort in the private sector, because in the public sector you get paid a salary, so regardless of what you do, while in the private sector, for example, you are paid by volume. That would have an impact on worse quality for the public sector. It might boost waiting lists because of what I was just telling you. If you have more waiting lists, that might send patients to the private practice that you yourself are in charge of, cream skimming, or interestingly, for example, also over-treatment, because precisely of this reputation building. So I want to build my reputation by showing how good I am. This means that I might want to do something that is very intensive, so that you can say, wow, and then with my reputation, go to the private sector. So basically, there are many arguments, pros, cons, and you can see, lots of arguments of people saying putting exclusivity is a great idea, taking out the exclusivity is even better, because, so putting the exclusivity usually is a good argument for more doctors for the public sector. That's the intended consequence of doing that. Some people say, wow, but that's very strange, because imagine two doctors that work exactly the same hours in the public sector. If one of them has extra hours in the private, they would be earning different in the public sector. Both working the same, both doing the same, let's say, good job, but the one that only is in the public would have this exclusivity, while the other, just because go somewhere else to do some extra hours, would lose this. So basically what we do in our research is to contribute to this, this literature by providing evidence on how doctors decide to engage in dual practice or not, because there's very little information on that. And there's in gray, maybe, not in this paper, but maybe with some later, to see what's the impact of that on the health of the population. So I'm going to be telling you about the first decision. We've been looking a little bit about what happens overall in the health of the population, but that's for another paper. So which are our questions? We want to see how doctors decide to engage or not in dual practice, and what's the implication that this has for the total hours of the total number of workers and the total hours of doctors in the public and in the private. Okay, let's see if we have more hours of doctors, less hours, and then who moves? The best ones, the worst ones, no difference. And to do that, we explore a unique natural experiment that we have in Spain, which is this exclusivity policy that I was just telling you about. Because different regions, some have always had it since the decentralization, some have never had it. Some have put it, some have taken it out, some have put different numbers, so that's something that we as researchers absolutely love, and that will give us a lot of things to explore. So our main results are, we have a theoretical model, and the theoretical model says, well, we could have things going in both directions. I will tell you a little bit about the theory, but I'm just going to be showing you the results, okay, the data. And by the way, the data that you are seeing is early stage, because we are expanding the time frame as of now, and also we are adding some better types of treatment. So I'm going to show you a little bit the latest data, but we still don't have the final one. So you are going to see a shorter time period. But basically what we find is that empirically, this exclusivity, what it does is to decrease the total hours of doctors in the public sector. And I'm going to tell you in a second. So the unintended consequence is this one. Precisely, you want to do that to have more doctors and more hours in the public sector, and what you end up having is actually less. And the ones that move are the listed skills. So I'm not going to tell you much about the Spanish healthcare system just because of what we have just heard, if you allow me. Maybe the only thing that I might want to add is that this private sector, 24% of the population has voluntarily private insurance, even though we have free, after finance with our taxes, but public insurance. And we have co-payment for pharma. But I don't want to talk more about that just because we had an amazing presentation just before me. So that these numbers, which you might see or not, depending on how far you are from here and how good your eyesight is. But basically, I just want to show you that there's a lot of variation. The thing that we were talking about, that's what you can see. So we have very many different numbers, some communities, some regions introducing the exclusividad, some taking it out. This, by the way, is super difficult data to get. It's very sad to say that, because in principle we should all be very transparent, but to get this data, it's a nightmare. And well, I mean, that's an example of some of the things that she was saying before, no? that we should all know that we are looking at the same complemento for the same type of doctor across the different regions, okay? And you can see that there's variation. So this exclusivity bonus, just to give you some more details, is, as we've said, the doctors that work, not all of them, but most of the professionals who work in the national health system are civil servants. They have their job and they cannot be kicked out. Not all of them, some of them. And we can separate between the ones who are and the ones who are not, by the way. The average annual salary of a doctor, of a specialist and primary care of a doctor, is 56,000 in Spain, in 56,000 euros in Spain in 2022. That, for some of your standards, as you can see, it's pretty low. And providers, these doctors can also work in the private sector. In our sample, we have 48% of the doctors who work only in the public sector, 38 who work only in the private sector, 14 who work in both places. Now, again, this is changing a little bit because we are expanding the number of years, but just so that you can see. And well, the exclusivity bonus, it's to compensate those who work in the public sector exclusively, as the name says. So we have a model of dual practice, just to give you some of the hypotheses that we are going to be testing. And we are interested in seeing this decision of working dual practice or only exclusively in the private sector from both margins, the extensive and the intensive. So when we look at the extensive margin, basically, you know what, you're gonna quit your job in the private sector, which is the intended consequence of this exclusivity in principle. Well, in principle, our hypothesis says, well, if I'm paying you to stay exclusive, that's a strong incentive for you to drop whatever thing it is that you are doing, the extra hours that you do in the private sector, and move and be only in the public sector. Okay, that's the hypothesis number one. Now, who will move? Well, if I make a lot of money for a few hours in the private sector, this exclusivity will not compensate me. So if I'm very high quality, assuming that quality is very related to the salary and whatever, then I'm less likely to move. So basically what happens is that this model predicts that the lower ability doctors are the ones that are more willing to switch given the exclusivity. And in terms of intensive margin, there the theory is very ambiguous. Because on the one hand, those who work in the public sector, I'm asking about the total number of hours, sorry. So here we want to see the total number of hours. In the public sector, on the one hand, I receive these who are public-private that quit the private and come and are only public, so I might have more hours there. On the other hand, the ones that were happy working in the private sector, in the public sector, now get paid a lot for nothing, for what they were doing before. So if they were doing some extra hours, some, you know, something in ER, they might say, wow, I get this money, so because of the income effect, they might drop the hours, okay? And the opposite happens in the private sector. In the private sector, you might see, on the one hand, a reduction of hours of the people who become public only, but on the other hand, because that might stress the need in the private sector, you might see some change in salaries or whatever and compensate in another way. So maybe the ones that are there work more hours. So just to say, you need to see the numbers to reach a conclusion. Basically, that's the idea. And let me tell you about the data that we have. So to explore this, we use the muestra continua de vidas laborales, which is the continuous sample of working lives, which basically what this thing does, it's a data set, kind of a nightmare of data set in terms of working with it, but it's fantastic because every year the Social Security gets a random sample of 4% of all the individuals that have had any type of interaction with Social Security. So this is anybody who works, anybody who is unemployed, anybody who has a maternity leave or any type of a relationship with and for this person, if this 4% is a person who is, let's say, 60, we get all the history, all the labor history. So I can go back of all the contracts that this person has ever signed. Public sector, private, anything. If I get a person who is 18, then obviously probably this person is in his or her first job, so we have less information. But going backwards, we have a lot of data, and we can link this to fiscal data. So we can know exactly how much money they make in each of the contracts. So basically we have a lot of information in this sense, and once we work with this data, we select obviously people who work in the healthcare sector, okay? And these are the ones that we focus on, and we classify them on whether they work only in the public sector, not necessarily in the same hospital, but just in, well, or practice, only in the private or public-private. And these are our descriptive statistics, so basically you might not be able to see that, but the share of public-private is around 14%, and this means that about 1/4, a little bit less, 23.5% of the doctors who work in the public sector have dual practice. Okay, so it's a significant amount, 14% of the total, 23.5% of the ones that work in the public sector. And then, because we care about data on the hours, we have amazing data on the contracts, but the contracts don't specify how many extra hours you do. Because a contract is a contract, of course you are paid by your extra hours, but we don't know. Okay, so for this, we use a sample which is smaller, but it's the Spanish labor force survey, which asks people about how many hours they work. This sample, it's slightly, not very different, it's just a little bit older than the one that we have from the muestra, but that's what we have. So that's what we are going to be looking at. So let me show you some of the results. The first one is what happens to the share of exclusive public workers. I don't want to bore you with all types of robustness that we've done, but obviously we know that because we have regions that have always had it, regions that have never had it, regions that put it, regions that take it. We have all types of these problems of two-way fixed effects, and that will mean that we need to be looking at different groups, for example, of countries, or we will need to correct for that. So let me show you the first set of results, which I'm going to be reading here because otherwise I don't see them. So let's see what's the effect of the exclusivity bonus on movers. We looked at 1,000 increase in the exclusivity bonus. This, if you increase the exclusivity bonus by 1,000, that would mean that you have an increase of 1% of exclusively public doctors. Okay, that's the data that we have. In all Spain, this increase will lead to this 1% increase in exclusive public doctors. So basically, this would reduce the dual practice by 4.3. So it's significant. I mean, you know, it's an important number. And here we put it into perspective, but basically with this exclusivity, we can explain 15% of the changes that you have annually between, you know, fully public or public-private. Another thing that I wanted to show you is that maybe people, another question that came to us is, hey, if another community pays me for exclusivity, and I'm a public doctor in one of them, do I switch to another hospital, public sector? Well, that's not that easy, as you might know if you know how it works, to switch hospitals and have your slot. So basically our data says no. We don't see people moving to a community. If you are a public sector doctor and in your community you do not have exclusivity, you don't move to another one. It's not significant. But of course, understanding how it works, which means that you need to, I mean, it's almost impossible to get a slot there, so it doesn't happen. Another thing that one might be considering is that since this exclusivity, it's for the public sector, in principle, if you are working on the private sector only, that should not make you drop anything or change anything, and that's what we find. You don't see changes, which is a good thing to know. No? You don't see changes in those who are in the private sector. And another thing that I wanted to show you, it's in columns 3 and 4, which you might not be able to see, but as you can observe, maybe these numbers are bigger. It's because in columns 1 and 2, we look at health professionals in general. In 3 and 4, we look at doctors, which are a proxy for doctors, given what we can see from the muestra, which basically are the ones that are affected, that receive this exclusivity complement. So when you look at the ones closer to the target of the exclusivity complement, that's what we see. Let me show you what I was mentioning. Because we have all these different types of variation across regions, changing the policies at different moments in time, we know we do have a problem, and when we do that, one good thing to look at is these event studies. So you pick all the ones that have not changed ever, their policy, and then you compare that with the ones that have taken it out, when they've taken it out. And for example, this is what I'm showing you here. We have, I'm going to show you more for the ones that put it in, but here you can see that before, in the pre-trend, they were similar, let's say, and then when you take the exclusivity out, then you see less share of public sector doctors. This is the data that we have been working so far, but obviously the pre-trend is very short. We know that. That's why we've extended this, okay? And we have better pre-trends going forward, which I'm gonna show you. Okay, so that's the intensive margin. Here we want to see what happens with the number of hours, okay? And as I was telling you, in principle, the data, our prediction is inconclusive. We need to see the data. So in the first column, you can see that when we put exclusivity, the number of hours does not change in total. However, we see a difference between the public sector and the private sector. So the total hours in the public sector actually decrease almost 1 hour a week, 0.9 hours a week, when you put exclusivity. So it basically means that, of course, since you have, most of the doctors in the public sector who are fully public, for them, you give them this extra money just because. So then what happens? That if you were doing some extra hour or you just don't do it. The income effect dominates. This dominates more than the extra doctors that become public only, okay? And the number of private hours increases, which basically means that, yes, some leave to the public sector, but the ones that remain there, the ones that are fully private, because you've lost the pub brief, let's say, the ones that were fully private, now need to work more. That's what it shows. Again, our prediction could go any way, but that's what we see, okay? Well, the conclusions, I think, that are quite striking in the sense that you were trying to get more hours of public doctors, and what you get is actually less. I've not shown you the data because I just had some few minutes on the skills, in part because I only had some few minutes, in part because the proxy for the skills is what it is. So let me tell you what we find so far. Okay, we don't know if this doctor is a dermatologist that treats these patients and what's the result of the patient. We cannot link doctors with patients. So what we do is to proxy skills for two things. Okay, we proxy them for age. So we assume, becoming a doctor, it's 6 years of doctors. So we say, well, the first 10 years when you are still practicing, you are less skilled. We could question that. Just as I'm saying, that's the proxy that we have. And there you can see which these are the ones that move more to the public sector. Another way of looking at the skill is to say, well, if you earn more in the private sector, it must be for something. So probably you are more skilled. Again, So that's the best we can do because we cannot link doctors to outcomes. So we will be able to tell you more, and we would love to do that about outcomes if we could link doctors to outcomes, but we cannot. So that's the most we can do. So basically, that's why you don't see the table, but we have it. Next steps. So what are we doing now? We are extending our time because what you saw is from 2016 to from 2006 to 2015. We've extended that from actually 2002, but 2002 it's a messy year because it's really the first year when all the communities had autonomy to decide, and then the ones that put it is in the middle or things like that. So we could start with 2002, but actually 2003, it's really when they've done whatever thing it is that they wanted to do since the beginning. And another thing that we are doing, so some people say, wow, maybe there's something else other than exclusivity that could be going on in different communities. And that's a tough one, because even if you know what happens when the referees tell you that, right? I mean, okay, what would that be? Right? Because we control for as many things as we can come up with, but it's never easy. But what we are doing now is we are looking at the sample of teachers and professors. Why? Because the education is also decentralized, so that in this sense is very similar to health. It's also a big part of the spending of the regions. And in health we have public sector, something that we call concertada, which are private hospitals that receive most of their funding through the public insurance, and then you have fully private hospitals. The same thing happens with the schools, with universities, so we have this type of variation, and with this, we hope that if we do a triple diff, so before, after, communities with exclusividad no, compared to what happens with the professors who don't receive exclusividad, so in principle nothing should happen to them, or whatever it is we should subtract, then we should get interesting results. Let me just show you with this new sample, I'm sorry because this doesn't look as good as but it's just from yesterday. So that's what it is. Let me see. So this is countries that removed the exclusividad. And as you can see, this is significant. This is the triple diff. So what we are doing here is to compare before and after with a synthetic sample of the ones that always stayed the same. The ones that took it off minus what happened to the percentage of public professors, teachers, all educators, all the group. Okay, and we can see that it's significant. And here we are doing some synthetic divs and divs. This is, by the way, for the taker. The taker would be Catalonia, so this is a region that put the exclusividad compared to the ones that remain the same. And again, you can see that when you put the exclusividad, the percentage of fully public increases, for example, and there we do a synthetic of the triple div with education. So, I mean, basically, that's it. Something else that we could maybe add is that when we did back of the envelope calculation, and again, here we have to be very careful, but when we look at outcomes on healthcare, this probably won't be in this paper, so that's why I'm saying we'll see. But when we look at outcomes in healthcare, we looked at everything, at mortality, at low birth weight infants, at avoidable hospitalizations, at anything that we could come up with. Really, we look, well, yes, we looked at everything, at technology used and everything, and we almost found nothing. Only a reduction in C-sections when you put exclusividad. That's the only thing that we found. And a reduction, a little reduction, on total hospitalizations, on days of hospital, which is not that surprising since you have less doctors, okay? But at the end, if you look at the little result that you could have, how much you would save in hospital days, let's say, compared to the cost of financing this, I mean, I have back of the envelope numbers, but I think we better share them when we have the full sample. But really, it's you know, a costly thing, let's say, for this. And thank you.
Thank you, Núria, and thanks all the speakers for your excellent presentations. So we have now some time for questions. So if you have questions, yes, please.
Núria, a couple of questions for Núria. Okay? In fact, I have tons of questions for you, but I'm going to shorten them and just make two of them. One, in your main regression with the muestra, you show unconditional regression. One possibility is just to separate two conditional regressions, movements into dual practice and movements out of dual practice. Yeah, for comparisons, because it could be asymmetric. And second, with the labor force survey or EPA, in this sample you are repeating individuals very frequently, especially in consecutive years. Maybe. If so, repeat the exercise just using one time each individual or introducing individual controls, individual specific effects.
Yes, we do, in the EPA we do that because they can come up to 6 times, so we are aware of, so we do that, and they only come once, so we take the second quarter, I think, yeah. And in the first part, we are working on this because we also think that this is asymmetric. The impact of putting exclusividad might be different from the taking out exclusividad. Mostly because taking out does not mean that I decrease your salary in most of the cases, because nobody dares to do that. Usually means I'm paying it to everybody. So obviously it's different keeping it. In the model, we could argue that what matters is the marginal, but still, you know, than really putting it on. So we are looking at whether that makes a difference or not, and we are separating takers from the ones that remove it. But we are working on this, so I still cannot tell you what happens. But yes, I think you are onto something, because probably we will find that it's not symmetric. Thank you.
Can you hear me? Yes, great. Yeah, so thank you everyone for the papers. They were brilliant. But like Sergi, I have comments on the final one, which I really enjoyed. I just want to mention that, of course, here we are talking about exclusivity, but we are not paying a lot. So there is a literature out there, not just in health, that about incentives. That often when you are not paying enough, then the effect is not like massive, right? So here we are finding only a 5% shift, which is basically on the margin, right? And there is a literature as well developed it's a literature on behavioral economics that talks about signals. So it could well be that those effects are not necessarily driven by income effects alone, but by the signal. When your, let's say, autonomous community tells you that they want you to be exclusive, and there is a literature on commitment devices, right? What basically they are telling you is, sign a document where you commit, right? Because in the end they will not probably inspect and look at the compliance of that. It will be very hard, I guess, to look at what every doctor is doing, right? So in practice, this is more of a behavioral effect, and I think that would be really promising to go that route. No, I wonder whether, and if there is an income effect, it could be that it's driven by night shifts. In the public sector, I had a girlfriend once that was a doctor, and and she was doing night shifts as a way of adding to her salary. So I wonder whether if you get that compliment, maybe you don't do night shifts anymore, right? And that could be an explanation. I guess that you cannot observe that in your data, but I think that could be a plausible explanation.
We tested a little bit our finding with, we asked people from the sector whether this made sense or not. The problem is, I will see if we know the hours of the day on the date. So we have where you work, the full-time, part-time. We'll see, I don't know, but that's a very good one. So if we could know whether it's a night shift, that would be wonderful. So thank you.
Any other question, comment? Oh, thank you. So I think we can now move to the closing remarks with Núria Mas and Martí Parellada. Thank you.
For our country, for our citizens, for our academy. And I think you can see the education and health is the main destination of our regional government's spending, but it's very important for us to know should be done about this issue. Huh? A very special thanks for Judit Vall. Was work is essential for the organization this workshop. And thank you very much for the Institut d'Estudis d'Autogovern for your support and for hosting us in this nice building today. Today is a very important or special day for us because this act This event is the first act, is the first event del Observatori de Federalisme Fiscal. L'Institut d'Economia de Barcelona, del qual ens n'han parlat aquest matí al començar aquest workshop, ha estat sempre compromès amb aquest tema, amb el del federalisme fiscal. El federalisme fiscal ha estat el pilar del que ens va portar a fundar aquest institut, que té per interès o que el seu principal objectiu és oferir coneixement sobre com ha de funcionar un estat que ha decidit que es volia descentralitzar. I ara hem cregut que volíem visibilitzar més aquest nostre compromís, fer més evident que hi ha una sèrie de membres d'aquest institut que ens volem dedicar a això, i de fet ens dediquem a això, ens hi hem dedicat tota la nostra vida professional, i volem fer més evident aquest compromís d'estar present en el debat sobre un tema que jo m'atreviria a dir que és un dels temes crucials per trobar aquest encaix del nostre país amb aquest estat. Jo no m'atreviré a fer unes conclusions del que s'ha parlat avui, jo no tinc l'expertesa per fer-ho i segurament la Judit ho faria més bé, però em tenta molt de dir algunes idees que m'he anat anotant i les compartiré molt breument. Jo crec que, d'alguna manera, amb les exposicions d'avui ens ha quedat clar que la descentralització d'una funció com aquesta, la sanitat, té avantatges, jo diria, però que aquestes avantatges, aprofitar-les depèn d'algunes coses. Jo diria que depèn de quina sigui la capacitat que tinguin els governs, que tinguin la responsabilitat d'aquesta competència de poder decidir sobre com gasten i sobre com ingressen. Jo crec que en cap altra funció és tan important el com s'ingressa, és a dir, d'on s'obtenen els ingressos per després poder ser gastats. Potser el cas de Noruega ens ha fet veure que potser el problema no és de la quantitat de recursos, allà en tenen, sinó de com es gasten aquests recursos i d'on venen els ingressos i, per tant, del model de finançament. I aquí volia anar a parar. El model, la construcció d'un model és molt necessari per poder entendre com es portaran a terme totes les competències que hem decidit que han d'estar descentralitzades. I el model el defineix alguns principis, com el de l'autonomia tributària, la capacitat de poder prendre decisions sobre com s'obtenen aquests ingressos i com això es fa compatible amb algun principi d'igualtat, equitat. Per tant, suficiència, autonomia, equitat, i d'això va el federalisme fiscal. Per tant, jo crec que s'ha demostrat que més que mai fa falta un observatori, en aquest cas un institut, i no només un institut, sinó tota aquella gent que espero que ens acompanyeu en aquesta nova aventura que tenim el plaer de poder dirigir la professora Núria Mas, que ens acompanya i que de fet estic parlant també en nom seu. Aquestes eren les idees claus del que jo m'he anat anotant i m'he resistit a poder compartir. Well, we hope that your stay in Barcelona was pleasant and we hope you see again in the future i enjoy Barcelona. Moltes gràcies.